We will be talking about blood, heart, and circulation today. So if you get the chance, you're going to want to go to Canvas and then look up underneath the announcement section, there's going to be an announcement for today's Zoom meeting, and in there it'll have the exam review guide as a link, but if you wanted to just go directly to Files, you could find it under Files under the exam review materials section. So, we will start with talking about blood. So basically, blood has the objective to be able to transport oxygen, carbon dioxide, nutrients to the cells, and carbon dioxide obviously away from the cells, heat to the cells, waste away from the cells, also things that go into global circulation like hormones. Its job is to regulate the pH of the body, the temperature of the body, the water content of the cells, etc. So its job basically is to maintain homeostasis. But it also is going to help have phagocytotic ability, which means that it's able to attack invading foreign things like microbes or bacteria. And it's also going to have its own clotting mechanism whereby it's able to prevent its own loss when we cut ourselves. So talking about the physical characteristics of blood, it's about 8% of all of your body weight, and the volume is approximately 4 to 6 liters in an adult. It has a greater viscosity than water, and generally the temperature is about 38 degrees C, so that's about body temperature, a little bit warmer than body temperature, about 100.4. Has a pH approximately 7.3 to 7.4, and it really doesn't vary very much from that. It has a really nice buffer system in there, the bicarbonate buffer system that keeps that pH nice and steady. Major components of the blood are going to include the plasma and the red blood cells. And this is going to be split up by centrifugation, so they spin it really fast, and the heavier things go to the bottom, so the blood cells are going to go to the bottom. And then we have the white blood cells here, and platelets, which are going to be the buffy coat in the central layer. They're going to be less numerous than the red blood cells, but they are still a cellular component. And then this plasma would be like an aqueous component. So about 55% of that is going to be plasma, and 45% is what's called formed elements. And it's called formed elements because platelets are kind of a weird in-between. They're not actually cells. They're like a blood cellular component. I'm just going to go ahead and hide myself here. So some of the things that are dissolved in this aqueous solution are going to include multiple different proteins. Some you might recognize, like albumins, like it's found in your sera, globulins, like hemoglobin, and fibrinogen, which is involved in the clotting response. Also going to have nutrients and enzymes and hormones and different respiratory gases that are being delivered or taken away, electrolytes and waste products, etc. So basically it's a delivery service. And this image depicts the approximate percentages in the body of the whole blood, 8% versus the rest of it, 92% other fluids and tissues. And if you look at that 8%, which is the whole blood, and split it up into plasma, approximately 55 and 45 being the formed elements. If we look just at that plasma, we were just talking, is mainly going to be water. But we also have some proteins and other solutes, and we mentioned some of the proteins, but there's several others in there as well. And then there's also things like electrolytes and nutrients and gases, which are solutes that are going to be distributed to the cells or taken away from the cells, like wastes. In the formed element region, we have platelets, which are not really cells, but are going to be involved in the clotting response. We have white blood cells. There's a bunch of different types of those. And then we have red blood cells, which are responsible for delivering. Hi. Oh, I'm sorry. There you go. My daughter just barged into the room. So we also have red blood cells, which are going to be responsible for delivering the actual oxygen to the tissues and, of course, carrying away the carbon dioxide. Of the white blood cells, there's several different types. We'll talk about each of them independently. That includes neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And the way that we differentiate those is generally going to be based on how they stain with a dye called Wright's stain. So if we're looking at the formed elements in blood, that's going to include your red blood cells. Those are called your erythrocytes. Your white blood cells, those are called leukocytes. And again, there's several of those all depicted here. And then also thrombocytes, which are platelets, which are, again, going to be involved in that clotting response. And this talks about the percentage of the volume occupied by blood cells. That's called hematocrit, and we can take a measure of an individual's hematocrit, which is going to be the percentage of the red blood cells in their whole blood, and then discover whether or not they have anemic or pre-anemic conditions if they have low amounts of the hematocrit. We can also have people who have high amounts of the hematocrit. That's called polypemia. So this diagram here depicts the formation of blood cells. If you remember when we were in class, we talked about this being something like a kindergartner, which could then go on through middle school or grade school and then high school and eventually go on to graduate school and have specialty degrees. So a kindergartner has lots of options in terms of their job opportunities. Same with this pluripotent stem cell. It can go down multiple different lines. And as it starts to travel down those lines, it becomes more differentiated into whatever it's going to become as an adult cell. And really, I think there's only a couple of questions on the exam about this, but really what you would like to know is what turns into what. So instead of having to know every step of the way, just know which one of these turns into what. Now, one of the questions that students ask quite often is about these CFUs, and CFU just means colony forming unit. It's a method of measurement. It's like saying inches or pounds. So you don't necessarily have to worry about CFUs. That's in front of all of them. It just means colony forming unit. But what comes after that is what's important. E for erythrocyte, Meg for megakaryocyte, GM for granular cyte, or macrophage, right? And if you look again, the pluripotent stem cell can split into two major lines to begin with, a lymphoid stem cell or a myeloid stem cell. And then each of those are going to go through their pro and then final version. So here's your proerythroblast becomes a erythrocyte, megakaryoblast becomes the platelets, etc. Again, with this region, the platelets are going to be very important because the megakaryocyte turning into platelets is going to cause that clotting response. Let's see. So really what I would like you to know from this diagram is which of these precursors turn into which of these adult cell shapes. Now, the lymphoid stem cell is going to be kind of a specialty one. It turns into lymphocytes and B and T lymphocytes, and these are going to be the type of cells that are going to be involved in the immune response. And we'll talk about that when we get to the immune section. We'll talk more specifically about that. So, in order to create these cells, that's called hematopoiesis or hemopoiesis, or the creation of these cells, and that's stimulated by multiple different growth factors. And you don't necessarily need to know which is which, but if you see the poietin, that means it's going to be stimulating the creation of. So erythropoietin would stimulate the creation of erythrocytes, right? Thrombopoietin would stimulate the creation of thrombocytes, which are platelet precursors. Here we're talking about red blood cells and what red blood cells do. Here's some of the red blood cell anatomy. Remember, it's a dimpled, it's got like a torus shape. It's anucleatic, that means it does not have nuclei. It's biconcave, so each side is going to have a dimple in it. And they have a specialty molecule called hemoglobin. Now, hemoglobin is going to be have these special 4 different sites. Each of them are going to be iron-containing. They're heme groups. And this iron is going to be where we're hitching a ride. I'm just making sure that I'm not muted still. Okay, just want to make sure that I'm not muted still. All right, so these guys we're going to be hitching a ride for our oxygen molecules or our carbon dioxide molecules. They're going to be sitting right here. Now, it's going to have a higher affinity for oxygen than it does for carbon dioxide, but it's basically going to be traveling around the body, dropping off oxygen until the oxygen gets so low that carbon dioxide is going to be higher, and then it's going to hop on here and travel back off so that we can have gas exchange, which happens in the lungs. About 33% of the red blood cell are these hemoglobin molecules, so it's almost all, at least a third hemoglobin molecules, and that's what gives it this nice red appearance. That red is going to be from the iron, and iron, when it forms with oxygen, is going to make iron oxide, which is going to make a nice, that's what basically rust is, a nice rust-colored molecule, and that's what makes these blood cells appear to be red. Now, the purpose of red blood cells is for them to transport oxygen and carbon dioxide, cellular waste, and energy. Right? And not energy, but temperature. So carry around heat energy. Now, hemoglobin also functions for the regulation of your blood pressure, and they can bind to nitrous oxide, and if nitrous oxide is present, it binds to hemoglobin. It can also release hemoglobin, and so this back and forth between picking up and releasing hemoglobin, releasing nitrous oxide by hemoglobin, can cause vasodilation and constriction, which is involved in blood flow and circulation. So it can enhance oxygen delivery to an area if we have more nitrous oxide. If we have less, it can deplete oxygen delivery to that area. All right, so the next one, here's showing the circulation lifespan of red blood cells. So after they enter into circulation, we'll start here. That's about 4 months or so, 120 days. And from there, then they're going to enter into their death cycle. So they're going to end up entering into death and phagocytosis. And this happens by way of a macrophage, so a specialty type of cell that's going to be found in the spleen, the liver, or the red bone marrow, where it's going to break down these red blood cells, and that's going to cause the release of molecules like globin, which can then get broken down because it's a protein broken down into its amino acids, which get recycled for protein synthesis. And then heme, which gets broken down into biliverdin, which gets broken down into bilirubin and processed by the liver through the small intestines and excreted. Yes.
About what?
Yes, I'm talking about blood, sweetheart. Yes, and then it's going to get excreted out through the kidney or the feces. So that's how we're going to be getting rid of the bilirubin byproducts. Another thing with the heme is going to get broken down into ferrin and transferrin, and that's going to get converted into ferritin, which is also going to happen in the liver. And then ferrin and transferrin is going to end up recycled back into the red bone marrow, where we can have what's called erythropoiesis. Erythropoiesis is obviously the creation of new blood cells. So this is back to where we're starting in terms of going back into circulation and the blood supply. And red blood cells have such a short lifespan because they have a lot of wear and tear because they squeeze through capillaries. Capillaries are very small. They're about the same width, so they're constantly undergoing this shear stress on the plasma membranes. But again, we're going to make sure we recycle all of these materials, so it's going to be broken down into its basic components and reused for either protein synthesis, etc. Sweetheart, I'm in the middle of a review session. Okay. Let's see. So what stimulates erythropoiesis? So what stimulates the creation of red blood cells? Hypoxic conditions are one of the main things. So if you end up with low oxygen conditions, that means you're not getting enough oxygen delivered to the tissues, and the body assumes that possibly that's happening because you don't have enough red blood cells. And so erythropoiesis is going to occur, again, in the bone marrow under the stimulation of hypoxic conditions. Okay, baby. And we're able to count the amount of, or the rate of erythropoiesis. And this is something that can help us in diagnostics, particularly in people that are ill or have anemic conditions already. So that's red blood cells. Do you have any questions on red blood cells? All right.
Just one. So the iron in heme is the element in which oxygen, carbon dioxide, and nitric oxide can integrate with. And
yes.
That's how it's like carried in the transport process? Okay.
Yes, but they have a different affinity.
Got it.
So the heme is more likely to bind oxygen than it does carbon dioxide. I'm not sure exactly where nitric oxide falls in there. It's a much lower percentage in the body. But my point is that when there's a lot of oxygen, it's going to be more likely that oxygen is bound to that iron. And then as it travels through the body, the oxygen starts getting delivered to the tissues, and there's more carbon dioxide, so that there's more likely that the carbon dioxide will bind to that heme. So when this blood returns to the lungs for reoxygenation and delivery of the carbon dioxide across the respiratory membrane, it'll be carrying 4 carbon dioxide molecules, and then on the way out, it'll be carrying 4 oxygen molecules, ideally, obviously, if we're at 100% saturation conditions.
Okay, got it.
Does that make sense?
It does, yes.
Alrighty. Okay, so let's move on to white blood cells. So white blood cells are called leukocytes, and these guys are nucleated. As you remember, the red blood cells had no nuclei. They also do not contain hemoglobin, so they're not there to drop off oxygen or deliver anything to the cells. What they're there for, well, there's a couple of reasons, but generally they're going to be involved in the immune response. So they're going to be the ones that are going to help attack foreign invaders. So we have 2 major types, and they're really just labeled based on what they look like. Are they granular or agranular? And that basically means, do we see these purple dots all over the place, or don't we? Right? And granular leukocytes are going to include eosinophils, like these guys, neutrophils, basophils, and then agranular leukocytes are going to include lymphocytes and monocytes. So granular on the left, these 3, agranular on the right, those 2. And these agranular ones are going to turn into macrophages. And you may have seen the macrophage previously. I'll scroll up when we were talking about degrading the red blood cells. Macrophages wander around and they degrade anything that's in their path, anything that's considered trash, whether it's cellular or whether it's something from outside, like like an invading microbe. So leukocytes have specialty surface proteins. Now, red blood cells do too, but these guys are called Mhc complexes. They're histocompatibility antigens, and these guys are going to be unique for every individual, obviously not identical siblings, but they're unique for a person, and they can also be used to identify not only the person, but also the tissue. So not only is this Dr. Griffiths' tissue, but it's Dr. Griffiths' heart tissue or Dr. Griffiths' lung tissue, right? So these are identification markers. Now, as I mentioned, the white blood cells, there's going to be less of them, for one, and they live for a shorter period of time. They only live for a few hours to a few days. Normally, we have about 5 to 10,000 of them per cubic millimeter of blood. Now, if we have an increase in the number of white blood cells, that's leukocytosis, and leukopenia would just be a low number of white blood cells. And if we have a low number of white blood cells, that might indicate that we are having a trouble issuing an immune response. Something like HIV might cause this, lower amounts of the T cells particularly. And the purpose of these leukocytes is to combat foreign invaders, so inflammation and infection. And what happens when they're traveling around the bloodstream is they're going to get some sort of information from the outside that says you're going to have to leave here to fight a foreign invader, and they leave by what's called emigration. And that happens like this. So here we have a neutrophil. It's just chilling, traveling along in the blood flow with the interstitial fluid, with the blood flow, the interstitial fluid's on the outside. As they're coming through here, then this is a neutrophil. It's going to bind, process of sticking, and it's going to do that by the fact that the neutrophil has these integrins shown in these little green boxes, and the endothelial cells have selectins, which are shown by these little, mattress spring things, and they're going to stick together, and that's going to cause it to extravate, or to squeeze out through the endothelial cells. Right? That's again this process of emigration, while they move over and extravate out through the cells. And again, they do this by this chemotaxis. So there's these different chemical markers. This is like the selectin-integrin interaction that I was talking about. That's going to give them the signal that says, hey, you should come over here because we have inflammation and infection in this region. Now, we have a couple different types of macrophages. So we can have fixed or wandering, basically. So we have neutrophils and then macrophages, which can be wandering or fixed. And these guys are going to attack foreign invaders by a process called phagocytosis. Basically, they're going to reach out with their cell membrane, wrap around and engulf a foreign invader, and then pull it into their cell. And then once it gets pulled in, it's going to go through similar like what you saw with the red blood cells in terms of being broken down and recycled for their basic components. Now, eosinophils are specialty white blood cells that are involved in allergic reactions. So they're going to be antihistamines, basically. And they're also going to be involved with phagocytosis, reaching out, engulfing, and destroying, bringing inside and destroying. They're going to phagocytose antigen-antibody complexes. And we'll talk about that when we get to the immune response, but this is a way in which we can get specialty attack to cells that we've targeted. And it's also going to allow us to combat parasitic worms. Basophils are going to turn into mast cells, and mast cells are going to be involved in releasing heparin. Heparin is going to be involved in blood clotting, so heparin is a blood thinner. Also, it's going to release histamine and serotonin in these allergic reactions. All of this is going to help intensify the inflammatory response, so it's going to be kind of a feed-forward mechanism that is going to make a greater and greater inflammation. Now, B lymphocytes and T lymphocytes are specialty, and we'll talk about them specifically when we get to immunology or the immunology lecture. But these are going to be coming from two different regions. These are going to be coming from the thymus, and then the B lymphocytes. Both of them are going to, let me back up and make this simplified. They both are going to recognize foreign substances that have these specialty markers on the outside. Those are called antigens. And these antigens on the foreign substances are going to be combated by antibodies. Okay, the antibodies are created either by the B lymphocytes or the T lymphocytes. The B lymphocytes create these antibodies for circulation, and T lymphocytes have antibodies on their surface that are going to attack the antigens. And basically, we can use these to have a specialty immune response, which is going to help prevent us from getting sick for a second time when we encounter an antigen that we've already previously attacked and destroyed. So these guys up here, neutrophils, eosinophils, basophils, are going to be kind of a global general response. They migrate around and attack whatever they're given, whereas these B lymphocytes and T lymphocytes are in a specialty immune response where they're going to attack something that they've already seen previously and already created these antibodies. And then after they've attacked it for the first time, they keep a select reserve of those antibodies that then come forward the next time that you see that cold again, which is why when a cold goes through a household, pretty much everybody gets sick once, and then that's it. The first person to get sick doesn't get sick again when the last person has it. The difference between B lymphocytes and T lymphocytes is that B lymphocytes make these antibodies that go into circulation, and then T lymphocytes are going to destroy the foreign invaders directly. It still works with antibody-antigen interaction, but it's just a little bit different. And we can take a look at the amount of our white blood cells by these diagnostic tests. Then we can look at which white blood cells are there and the percentage not only of white blood cells of the whole blood, but the percentage of the different types of white blood cells. And since we know that each white blood cell has a specialty role, if we know what percentage of each of the white blood cells we have, that can assist us in diagnosing whatever the problem is that this individual might be facing. Okay, so let's move on to platelets. As you remember, platelets are going to come from megakaryocytes. Megakaryocytes come from myeloid stem cells, so these stem cells turn into megakaryocyte-forming cells that turn into megakaryoblasts. Megakaryoblasts turn into megakaryocytes. Megakaryocytes fragment into many, many, many different platelets. Now, platelets we have quite a lot of per millimeter, approximately per millimeter cubed of blood, approximately 250 to 400,000 platelets. And they have a lifespan that's pretty short, only 5 to 9 days. Now, these aren't actually cells. These are cellular components or cellular fragments, kind of. They're formed components of the blood. And they're also going to be removed by macrophages, just like we saw with the red blood cells. That happens in the spleen and the liver. And the purpose of platelets is to help stave off blood loss. Again, we do this by making a platelet plug. And they're going to do that by pulling in fibrin. There's a whole pathway. We'll talk about that pathway when we talk about the clotting response in just a couple pages. So what we can do, I should delete that. We make a complete blood count where we're testing for total amount of blood and the amount of white blood and the amount of red blood cells, the different types of white blood cells. So it's going to include the red blood cell count, the white blood cell count, platelets per microliter of blood, hematocrit, and differential white blood cell counts. And this is all going to help us if we are trying to diagnose someone who is coming to us with some sort of disorder. All right, so if we have an issue with our bone marrow, we can have a stem cell transplant from an individual that has normal bone marrow and help individuals with something like anemia or leukemia or other blood disorders potentially recover, sometimes permanently, oftentimes needing repeated transplants. And we can also use cord blood for this as well. Now, the issue with this is that sometimes we have the rejection problems. So we can have the residual host T cells can reject the transplant, and sometimes the transplanted T cells can attack the host. So we want to make sure that we're reducing this immune response. Usually these individuals are going to have to take anti-rejection drugs, similar to individuals who are taking on a whole organ. Now, a cord blood transplant is different because we're taking their cord blood from their umbilical cord when they were a child, when they were first born, and that's not going to cause any rejection issues because they're from the host tissue. So they should be, instead of self, non-self issues, they're both self, so we shouldn't have a problem there. Okay, so this here is talking about hemiostasis, which is clotting. It's the clotting response, right? And so what happens is the blood vessels are going to get damaged, and when that happens...
Bad words.
No, these aren't bad words. They're just words you don't know, baby. So hemostasis basically happens when we're stopping the bleeding, and that happens when we have damage to the blood vessels. And we're going to make sure this is pretty fast because we want to make sure that we're staving off bleeding as quickly as possible. So here's our circulating platelets and red blood cells. You see circulating platelets are normally in a position where they're not going to adhere to the wall. But if we end up with damage, right, here's a damaged endothelium, that's going to liberate certain things, including thromboxane, serotonin, and ADP. All of that is going to cause the platelets that are in the surrounding area to change shape. So everything that's going to be in the area of these liberated molecules will form these plug-style shapes, which is going to then cause us aggregates and hopefully stave off the bleeding. So we have three major stages of hemostasis. The first is the vascular spasm. And the vascular spasm happens when the constriction of the blood vessel wall occurs, and that's going to help stave off some of the bleeding. Secondarily, we have the platelet plug formation, which that happens here with the clumping of platelets around the damage, also helping to stave off the bleeding. And last but not least, we have coagulation, or the clotting response. And here's what that looks like. So here's the platelets and the red blood cells. These here are fibrin threads. And in the early stages of that response, the fibrin threads are going to kind of aggregate around the red blood cells. In the intermediate stage, they're going to elongate, and during that third stage, they're going to tighten down. Now, we're going to trap some red blood cells in here, but typically this is going to make an actual clot, and then around this, we're going to allow the passage of other red blood cells. So a clot is basically a gel of those insoluble protein, the fibrin, which is going to have the formed elements of blood trapped in there, right, the red blood cells. And all the chemicals involved are known as clotting factors, and we're going to talk about them in a minute. Most of them are found in blood plasma. Some of them are going to be released by platelets that are going to be in circulation, and one of them is released by the damaged tissue cells. So we need to have a conglomerate of factors coming from the blood plasma, the platelets, and the damaged endothelial tissue. Now, as we talked about in class, there are three major stages of blood clotting. The first is the formation of what's called prothrombinase. This is going to be an activator of prothrombin. The next is going to be when we're converting prothrombin into thrombin. And the third stage is when we are converting fibrinogen into insoluble fibrin. So fibrinogen is soluble, it will circulate through the blood supply. Fibrin is insoluble, it will form that thick clot that we were talking about. And while we can take either the extrinsic or the intrinsic pathway to get there, we're going to get to the activation of thrombin by prothrombin. And this is really when we start the clotting response. Now, the extrinsic pathway is when we have tissue trauma from the external environment. The intrinsic pathway is when we have tissue trauma from the internal environment, from a damaged endothelial layer. Either way, we're going to end up with calcium brought in and activation of X, right, our blood clotting factor X, which is then going to lead to prothrombinase. So once prothrombinase is available, we enter into the common pathway, whereby we are going to activate thrombin. Now, in the intrinsic pathway, it's a little bit more complicated in that we have damaged platelets, which cause that activated platelets, and we also are going to have activation of 7, but that is going to bring in calcium and lead to activated X, right? And activated X and activated 5 coming together with calcium is going to lead to prothrombinase. That's going to lead to the activation of thrombin and then the strengthening down of those fibrinogen into fibrin, right? So once fibrinogen, which is soluble, gets converted to fibrin, which is insoluble, and then strengthened down, now we're going to have a nice tight clot that's going to be able to allow passage of blood around it. So again, that clotting cascade can be initiated by either the extrinsic or the intrinsic pathway, but once it reaches this common pathway, all the steps are going to be the same. Now, coagulation is also going to involve vitamin K, and also is going to involve the retraction of the clot. It's going to tighten down as we strengthen down those fibrin threads, and then eventually we're going to enter into fibrinolysis, or when we dissolve the clot, which is going to happen after we've gotten the tissue repaired. So the fibrinolytic system is going to take inappropriate clots, or clots that are no longer needed, once the damage is repaired, right, and then break it down. And we can do that by fibrinolysin, which is found in the plasma, or it's called plasmin, and it's going to dissolve the clot by breaking down the fibrin threads and inactivating some of the other substances like factors 5, 7, and 8, which are known to be involved in the clotting pathway, right? So if we inactivate the factors that are maintaining the clotting, then we can focus more on the clotting itself. All right, so clots are going to be generally localized due to fibrin absorbing thrombin in the clot, the clotting factors diffusing through the blood, and the production of what's called prostacyclin. And this is going to be an inhibitor of the adhesion of the platelets, and it's going to allow it to release. Things that are going to inhibit coagulation are called anticoagulants, and I just talked about one being present in the blood. An example of that is heparin, right, which we just spoke about previously. Now, if some individuals have high clotting risk, and they might take anticoagulant drugs such as heparin or warfarin. Additionally, when we have donated blood, we want to make sure that we add certain things to it, such as like EDTA or CPD, and these are all going to be calcium chelators. We're basically going to be taking calcium out of solution, and if we remove calcium, of course, then we're going to stop the pathway here and not get to the clotting. Now, if we end up with clotting in an unbroken blood vessel, that's called thrombosis. And we might hear the word deep vein thrombosis, right? Or DVT, and that's basically what happens when the deep veins of the lower limbs are going to end up with clots in them. And then they can throw that clot or dislodge that clot, which can then, depending on where it ends up lodging, lead to a heart attack or a stroke. So we can have a couple different things that can be transported in the bloodstream that are not supposed to be there. That includes things like a thrombus, like the clot, or a bubble of air. Or sometimes if we break a bone, we can release the fat from inside, and then that can get, like from the marrow, and that can get released into the bloodstream. Or sometimes just debris that's transported from its site of origin. So if we end up with like a splinter and that splinter ends up going through the blood supply, anything that's not supposed to be there, that's all called an embolus, which can lead to an embolism. Now, aspirin can be something that you want to take if you want to inhibit the constriction of your blood vessels or vasoconstriction. Also can take it as a platelet aggregation inhibitor, and that's going to help reduce the chance of creating these thrombus. So individuals that might be at risk for deep vein thrombosis might want to take aspirin daily. Sometimes individuals that have clots that they already know about, right, they've already detected them, can have something that's called a thrombolytic agent injected, and that will help dissolve clots that have already been formed within the body. Some examples of this are streptokinase or TPS, tissue plasminogen activator. Okay, so let's move on to blood groups and blood types, unless you have any questions about the clotting response.
Nope.
All right.
Thank you.
Fantastic. All right, so blood groups and blood types basically have to do with what's on the surface of the red blood cells as well as what's circulating in the plasma. And if we have an antigen and an antibody of the same type, so A antigen and A antibody, we're going to end up with an antibody-antigen response. And we want to obviously avoid that. So you'll note that if we have the A antigen, we do not have the A antibody. We only have the B antibody. If we have the B antigen, we do not have the B antibody. We only have the A antibody. And that's why if we have the A and the B antigen, we have neither antibody because we don't want the antibody response. But if we have neither A nor B antigen, then we could have antibodies to either because we still won't elicit a response. Okay? So that's how we define the different types of the blood. Do you have the A antigen? Do you have the B antigen? Do you have both? Or do you have neither, right? And that's basically how we differentiate A, B, AB, and O. Now, the interesting thing about this is that they are what's called codominant, but we also have a dominant recessive thing happening. So A and B are what's called codominant. It means that if A and B are both present, they're both going to present a phenotype. But A and B are both dominant over the O type, which is recessive. So if we have BO, it's going to appear as B. If we have AO, it's going to appear as A. If we get O blood, it's only going to be if we have two O's. So this is going to be two recessive copies. So even though we have three different alleles we can have, A, B, or O, we have four different blood types because we can have A, which can be denoted as someone who has AA in their genes or AO in their genes. Someone who has BB or BO in their genes would be type B. Someone who has AB would be considered AB, right? And someone who has neither A nor B would mean they would be OO, would be type O blood. Now, just to make this a little bit more complicated, we also have the RH system. Now, the RH system is just a simple dominant recessive. Is it present or is it absent? And we would just call that positive or negative for RH factor. Right, so in the RH system, individuals who have Rh agglutinin are classified as Rh positive. Those who lack it are just going to be Rh negative. Now, this is only something that is really going to be an issue if we're dealing with transfusions, for one, because you want to make sure that negative is with negative and positive is with positive, right? But you also want to make sure in pregnancy that the fetus and the maternal genotypes are compatible. So if we have what's called an Rh incompatibility, it can cause a problem not in the first fetus, and I'll discuss why in a second, but in the second fetus. So let's start with the first pregnancy. In the first pregnancy, here we have an Rh negative mother, and she is going to have an Rh positive fetus, which creates Rh positive antigens. Those antigens are going to enter into the maternal circulation via the placenta, whereby she's going to create Rh antibodies. Now, these Rh antibodies are not going to affect this fetus because they are going to be created much later in this pregnancy, past the point when we're going to have an issue with this gestation. But with the second Rh positive fetus, so if she gets a second pregnancy whereby that fetus is positive, now the antibodies that she already has in her circulation are going to cross back across the placenta and cause an antibody-antigen response in that second fetus. So this is something that's called hemolytic disease of the newborn, and it's something that is treatable, but it's also preventable, and obviously we want to try to prevent that. We'll be doing that by a couple of ways. We'll be monitoring during the first pregnancy if possible to make sure that we are just going to put her on some sort of something that's going to reduce the amount of these antibodies that are created in the first type, like an immunosuppressant. And then here, we'll make sure that we're actively blocking these Rh antibodies from getting across that membrane to be able to attack that Rh positive fetus. Now, the reason that all of these blood types really even came to be, the understanding of these blood types even came into being is because of transfusions, right? If you transfuse the wrong blood type into the wrong individual, you can end up with an antibody-antigen response, and that can cause an issue. It will cause death in the individual if you cause a mismatch in blood types. But we're also able to use blood types to demonstrate paternity, link a suspect to a crime, or to study a relationship among different races, so they can be used in anthropology. All right, so this here is what we did in lab. This is when we're going to be detecting different antibodies and antigens in the bloodstream of individuals. And we do this very simple way. Basically, we're going to take a drop of the blood that's going to be what we consider to be unknown. Although here, obviously, these are unknown. These are known, so this would be blood type A, B, and O, and then theoretically we would have an unknown underneath here, and we would match it up. And when we have untreated blood, you can see you have what's called agglutination, and sometimes students were mixing that up with what's called a clotting response. This is not actually blood clotting. This is the antibody-antigen response, so this is going to be different from that clotting response that we saw with all those clotting factors. But untreated blood in all cases has no agglutination, so no globules that are going to be occurring. And if we treat it with the anti-A serum, only the individuals that have A, so A and AB, are going to have a reaction. If we treat it with B, only the individuals that have B, so B and AB, are going to have a reaction. And you can see with O blood, we don't get a reaction with either. So again, with A, we'll get a reaction with the anti-A. With B, we'll get a reaction with the anti-B. With AB, we'll get a reaction with both A and B. And with O, we'll get a reaction with neither of them. Now, RH is going to be doing the same thing. We're just going to add one more treatment. In the lab, it was called anti-D, but it's just an RH treatment. And again, it's either going to clot, well, not clot, again, agglutinate, or not. Right? And if we have this agglutination reaction, then we know that we have both the antibody and the antigen. And since we put down the antibody, we know we had the antigen present to begin with. Right? And again, we want to make sure that we cross-type when we're determining your blood type to make sure that we are going to be matching compatible blood types so that we don't end up with this agglutination reaction occurring inside the body because it can be fatal. Now, some individuals are going to have low amounts of their red blood cells. That's going to result in anemia, where we have the reduced capacity of the blood to carry oxygen. It's typically going to be a symptom and not a diagnosis. So anemia is not actually a condition, it's a symptom of a condition, but it's a symptom of many conditions. So it's used generally as a springboard to characterize what's wrong with the individual. Typically, what's wrong is a decreased erythrocyte counts or a hemoglobin deficiency. And there's multiple different kinds of anemia. Usually it has to do with the low iron, particularly in pregnancy. So if it's pregnancy anemia, typically they're just going to be given iron supplements. But then there's other types of anemia as well, like thalassemia, which is a genetic disorder, etc. And we also talked about sickle cell disease when we have an abnormal type of hemoglobin that causes a sickle shape of the red blood cells, which reduces their capacity for carrying oxygen. We talked about hemophilia, which is going to be individuals who have an aberrant clotting response. So bleeding can occur after minor trauma and is going to be sustained for long periods of time. So even a very small cut may bleed for a long while. If we have blood cancer, it can be leukemia, right? Leukemia is a malignant disorder where we can have issues of the blood forming tissues, so uncontrolled production and accumulation, which is what cancer does, right? It goes crazy in terms of the amount of cells that are produced, and if it occurs in leukocytes or immature leukocytes, it's called leukemia. And we can have acute or chronic leukemia. In chronic leukemia, we have an accumulation of mature leukocytes. In acute leukemia, we're going to have an accumulation of immature leukocytes. So basically what happens is, are we making too many of them at the beginning, or are they hanging around for too long because they don't die at the end of their normal lifespan? Either way, we're going to end up with too many of them, which can be very bad for the body and typically can result in needing a bone marrow transplant. All right, so that's going to summarize blood. Do we have any questions on blood before I move on to the heart? Nope. All right. I'm going to move on then. So the cardiovascular system is going to include things like the heart, the blood vessels, etc. Anything that's going to be involved in transporting blood through the circulatory system. The heart's generally a major pump. It has 4 major chambers that are all going to beat rhythmically to be able to push an estimated through the blood through approximately 75,000 miles of blood vessels throughout the body. And if you're studying heart and normal heart and diseased heart, that's known as cardiology. Now, where is the heart located? Going to be located in between the lungs and what's called the mediastinum. So here. And about 2/3 of its mass is to the left of the midline. So they say put your hand to your heart, or you put it all the way to the left. Typically, people are going to put their hand here. It's actually pretty much right in the middle, just a little bit to the left. And the lobes of the lung are going to compensate. So when we talk about pulmonary anatomy, you'll see that we're going to have a little bit of compensation here in the left lung for the heart itself. Now, the heart is going to lie between 2 rigid structures, the vertebrae in the back and the sternum in the front. And so if we're going to have to perform what's called CPR, right, called cardiopulmonary resuscitation, you can do that by heart compressions. So by pushing down on the heart from the top, you'll be forcing the rigid structures of the sternum and the vertebral column to push together, which is going to compress the heart and force the blood out and into circulation. Okay, so we have talked about the pericardium. The pericardium is going to be the sac that surrounds the heart. The pericardial cavity is going to be this in between these 2 layers. We have 2 layers, the visceral layer, which is what's going to line the actual heart itself. The parietal layer is going to be on the other side, lining the outside. So we have the pericardial cavity in between, and that's going to allow the heart to pump without having a lot of friction and external stress. So it's not actually going to be rubbing directly on tissue. Again, the pericardium has an outside layer and an inside layer. The outside layer is fibrous. This inside the pericardial layer, this pericardial cavity, is going to be the serous pericardium. Serous pericardium, again, has an inside layer that's going to be lining the heart. That's the visceral layer, and an outer layer that's going to be lining inside towards the lungs, and that's, again, called the parietal layer out here. Again, inside there we have a serous pericardium that's going to have fluid, and this is going to allow the heart to beat to reduce friction between those 2 membranes. And if we end up with inflammation here, that's called pericarditis. Sometimes we can have bleeding in this pericardial cavity, and if we end up with blood in here, as you can imagine, that's going to increase the pressure. And if we have pressure on there, that's going to cause cardiac tamponade, or a compression of the heart. And this can be lethal depending on the amount of blood that's inside there, because if we have too much pressure here, you can imagine the heart's not able to beat, which means it's not going to be able to fill up fully. All right, so this shows you the layers of the heart starting from the outside in. We're going to have the pericardium, the myocardium, and the endocardium. The pericardium surrounds the whole thing. We're going to have the epicardium, the myocardium, and the endocardium. I apologize. So here's the pericardial layer. Then here's the epicardium there. And then we have the myocardium, which is all this cardiac tissue inside here. And then the endocardium is the inner layer, which is actually going to be touching the blood. And if we end up with inflammation of these regions, that's called myocarditis and endocarditis, depending on what's going to be inflamed. And as you can imagine, inflammation of this region can be very painful and also can reduce and compromise blood flow. Now, as I mentioned, we have 4 chambers of the heart. We have 2 atria and 2 ventricles. The atria are on the top, the ventricles are on the bottom. And when we talk about the blood supply, we're going to be starting with that right atria, which is where blood's going to be coming in from the superior and inferior vena cava, as well as the coronary sinus. And then it's going to slow fill in that right atria, then it's going to drain basically into the right ventricle. From there, it'll get compressed out to go to the lungs. It'll do that from the pulmonary arteries. As you may recall from class, this is the only time that you're going to see pulmonary or any arteries. Anytime in the body, you're going to see arteries depicted as blue and veins depicted as red or pink. And that's just because arteries and veins typically mean whether they're traveling to the heart or away from the heart, which 99% of the time correlates with oxygenated and deoxygenated. But unfortunately, in this case, it is traveling away from the heart, but it's deoxygenated blood because it hasn't hit the lungs yet. So again, arteries here are going to be depicted as blue, and the pulmonary veins are going to be depicted as red. Anyway, coming out of that right ventricle, we're going to go out through the pulmonary arteries, going to come back in through the pulmonary veins into the left atria, going to go through that valve there into the left ventricle, and then out the aorta. Okay, some of the other things that we're going to talk about as we travel through the rest of this lecture are going to include the branches of the aorta. You can see the branches are going to include the brachiocephalic trunk, the common carotid artery, and the subclavian artery. Coming back in, we've got the vena cava. We have the superior and the inferior vena cava, which both feed into the right atria. We also, again, have those pulmonary arteries, pulmonary veins, and the pulmonary trunk here is going to be the region that's going to be feeding out into those pulmonary veins. Sorry, pulmonary arteries. All right. Let's see, what did I miss here? I feel like I've touched on, I guess I haven't talked about the vasculature of the heart itself. So coronary circulation, you will need to know the coronary circulation as well. There's 2 major branches, posterior and posterior and anterior. And they're each going to split, and those are going to be when we talk about something like a bypass. Remember, if you have like a quadruple bypass, those are going to be the arteries that we're going to be having, or the veins, I apologize, that are going to have bypasses done. On the surface of the heart, we have things called auricles and sulci, which are basically just going to be pouches and grooves that are found on different regions of the heart itself. Okay, what else is here that I didn't touch on? I think I touched on everything there. All right, so let's move on here talking about blood flow. I know I kind of touched on it, but now that we have a cross section here, a frontal section here, I can show you the region of blood flow. So again, we're going to start with this right atria, and blood's going to come in through the right atria from the superior vena cava, the inferior vena cava, and from this little region here, which is the opening of the coronary sinus. So yes, there are 3 major holes into the right atria. And as you recall, by this point, we have very little pressure. So this is happening mainly by drainage and almost by suction that's going to occur. So this is going to come in at very low pressure, and it's just going to kind of trickle in, and then it's going to travel through this tricuspid valve into the right ventricle. From the right ventricle, when the right ventricle is going to contract, now we're going to induce pressure that's going to push that blood out. It's going to leave through the pulmonary valve, which is one of the semilunar valves. The other is the aortic valve. Leaves through the pulmonary valve to head out to the pulmonary, from the pulmonary trunk into the pulmonary arteries. Again, these are blue arteries. It's going to return by these red veins, and it's going to enter into the left atrium. From the left atrium, we're going to go through that bicuspid valve. It's also known as the mitral valve, and we're going to enter into the left ventricle. As you note here, the left ventricle has really thick walls, and that's because it's going to have the strongest force of contraction, right? Much stronger than the right. We're only going to have kind of drainage of blood, or maybe by suction. This is going to happen by pressure. So when this contracts, we're going to be forcing everything out through the aorta, traveling through that aortic valve into the aortic arch, and then it's going to reach those 3 branches of the aortic arch that we talked about previously. Okay, so this just talks about everything that I just said. Right atria gets blood from 3 regions: superior and inferior vena cava, as well as the coronary sinus. This I didn't mention. I'm not even sure I brought this up in class, but there's a region that's called the Fossa Ovalis, and it's just an indentation in the septum that separates the right and the left atria, and that's basically going to be a remnant of the foramen ovale. So blood passing from the right atria into the right ventricle does that through the tricuspid valve. Blood passing from the left atrium into the left ventricle does that through the bicuspid valve. And as we're heading from the right ventricle out to the pulmonary trunk, it does that through the pulmonary valve, which is one of the semilunar valves. As we're headed out from the left ventricle into the aorta, it does that through the aortic valve. From the aortic semilunar valve into the aorta. Additionally, and this is not on the exam, but the fetal blood supply is a little bit different. And during fetal life, we have something called the Ductus Arteriosus, which is going to have an extra. It's basically going to be our fourth arch. It's going to be the fourth branch that comes out of that arch. It's actually going to be here, going to connect these two. And that's going to close up and become the ligamentum arteriosum in the adult. So we actually are going to have a fourth branch off of the aortic arch in the fetus that we do not have in the adults. Again, we have different thicknesses of the myocardium, and that's going to vary depending on function. The atria are thinner than the ventricles because they don't need to have as much strength. The ventricles are going to be the ones that have the contractile strength. However, the left ventricle needs much more because it's going to be pushing against and into the entire aorta and for systemic circulation, whereas we're just going to have drainage basically happening from the right atria through into the right ventricle. And yes, it does have to contract to squeeze out to the pulmonary, but it's pulmonary circulation, but it doesn't need as much force to do that as the left ventricle does to go out into systemic circulation. Much greater resistance in systemic circulation. This one just depicts all of the different valves. And I chose this image in particular because I wanted to make sure that it's clear that these valves open in concert with one another. Okay, so the bicuspid and the tricuspid open at the opposite time that the pulmonary and the aortic valves open. And for one moment, as depicted here, all four of them are closed. So 2 open, all 4 closed, the other 2 open, all 4 closed. In between each of them, there's a moment when all of them are closed so that we don't have any backwash. It's just a heartbeat, well, less than a heartbeat, obviously. All right, so this also shows the fibrous skeleton. So here's the pulmonary fibrous ring, which is going to surround the pulmonary valve. We're going to have the aortic fibrous ring, which is going to surround the aortic valve. We have the atrioventricular fibrous ring on the left and the right, which surround the bicuspid and the tricuspid valves. And these are all going to be part of the structure so that the heart valves have something to attach to. They also serve as insertion points for cardiac muscle bundles and keep the valves from overstretching when blood passes through and forces backwards with resistance. Additionally, they're going to act as an electrical insulator because, as you might imagine, we have electrical impulses that are coming into the atria at a different time than electrical impulses to the ventricles. So that's going to prevent the direct spread of that action potential from the atria to the ventricles. All right, so this is showing you the heart valves and how they work. So this is one that is going to be open during that time frame. The chordae tendendae are going to be slack and relaxed. Blood is going to be flowing this direction. Now, when the opposite part of the heartbeat happens and blood starts pushing backwards, now we're going to have it closed and blood's going to bounce off the inside of that cusp of the valve, causing these chordae tendendae to be taut, which is going to keep these valves from overextending backwards, right? And these muscles are going to be contracted. So the atrioventricular valves are going to be responsible for preventing backflow into the atria from the ventricles. And the chordae tendendae play a role in this by the contraction of the papillary muscles, tightening them down, which prevents the valves from what's called everting or turning inward, right, which would would allow the blood flow backwards. So this is showing what's happening when we have equal and opposite. So this is when we are going to have the pulmonary and aortic valves closed and the bicuspid and tricuspid valves open. And here is when we're going to have the bicuspid and tricuspid valves closed and the aortic valves open. And remember, blood flow is going different directions. So here, blood flow is going into those tricuspid valves, and here it's coming out of or towards us from the pulmonary and the aortic valves. Now, the semilunar valves are going to allow blood to leave, but not come back, right? These are like bouncers at 1 a.m. You can exit the club, but you can't come back in. And the semilunar valves are going to open when the pressure inside the ventricles exceeds the pressure in the arteries. And that happens when we're going to squeeze those ventricles really hard, forcing that blood to pop outward. And we can have heart valve disorders, like a leakage or a hole in these valves, or that eversion that we were talking about, that can allow blood through the heart to be diminished. Now let's talk about different types of circulation. So we have systemic circulation, pulmonary circulation, and coronary circulation. So the left side of the heart basically pumps the blood out for systemic circulation. This is what's going to go out through the aorta and go bring the oxygenated blood to all of the vessels of the body. And the right side is going to be the pump for pulmonary circulation, where it's going to take deoxygenated blood from the body and send it to the lungs for gas exchange. Whoa. So this is just going to basically be a path of the blood flow through the heart that also includes the oxygen level. So we have oxygen poor blood here coming into the right atria. Again, it's going to happen from 3 different ways. Only 2 are depicted here, the inferior and superior vena cava. But we're also going to have blood flow from the coronary sinus, which is depicted right here by a little hole. Then it's going to travel into the right ventricle. From there, it's going to head out through the pulmonary trunk, right, through the pulmonary valve, out into pulmonary arteries in order to go into the pulmonary capillaries of the left and right lungs, and then come back in. It's going to enter back in on the left side in the left atria here, and then travel into the left ventricle, where it's going to be exported out through the aorta and then out to systemic circulation. Systemic circulation is going to include these 3 major branches, whereby we're going to go brachiocephalic, and then this is going to be carotid, and then this one is going to go to the subclavian. All right, so in the pulmonary capillaries, what are we doing? And we'll talk more about gas exchange when we get to respiration, so that's going to get its own chapter. But just to kind of give you an idea, what happens is that we are going to have blood that's going to head out. Let's start where blood's coming into the heart, so because I know it's a circle. So let's start here, actually. Blood's coming into the heart from the superior vena cava, the inferior vena cava, and the coronary sinus into the right atrium. That's deoxygenated blood from the atrium. It goes through the tricuspid valve to the right ventricle, then out through the pulmonary valve to the pulmonary arteries after the pulmonary trunk. Then it's going to enter into the pulmonary capillaries, where it's going to have gas exchange occurring. We're going to lose our carbon dioxide, pick up our oxygen, and then that oxygenated blood is going to travel through the pulmonary veins into the left atrium, through the bicuspid valve to the left ventricle, through the aortic valve out to the aorta, and the systemic circulation. During systemic circulation, the opposite is going to happen. We're going to lose oxygen and gain carbon dioxide, and then return with deoxygenated blood to lather, rinse, repeat this cycle. All right, coronary circulation is basically when we're going to have the blood flow through the myocardium of the heart. And this is going to be a very short cycle. It's going to come straight off of the aorta, go through coronary circulation, and dump right back into the right atria. And that's because the heart's going to use so much oxygen that it's going to really deplete the oxygen supply of that blood. So this coronary circulation serves to deliver oxygenated blood and nutrients and remove carbon dioxide and waste from the myocardium itself. And that looks like this. So here's our anterior view. We'll show the posterior view in a moment. We're going to have the anterior interventricular branch, which is depicted here, and the posterior, which is it's depicted kind of as clear, right? The posterior branch is going to come here. The posterior interventricular branch. And these are going to split off into the marginal branches and the circumflex branches. And then if we're looking at the anterior view of the coronary veins, here we have the great cardiac vein here, and the middle cardiac vein, which is shown in the back there, and the anterior cardiac vein, right? And all of that is going to then lead to the coronary sinus and dump into the right atrium. Okay, so coronary arteries are going to be the arteries that are going to branch off from the ascending aorta. Again, that's the left and the right coronary artery. The coronary veins are going to be taken in through that principal vein, which is going to have those three major regions, the great, the middle, and the anterior cardiac. And that's all going to dump into the coronary sinus, which is going to dump directly into the right atrium. Right. Let's see. And if we have blockage of a coronary artery, we can end up with damage to the tissue. So it could, because we're going to be depriving the heart muscle of oxygen. And so we can need to use drugs. Sometimes we'll give these individuals drugs that'll help lessen the damage after a heart attack. Let's see. If we end up with low levels of oxygen in the myocardium, the heart cells end up weakened. That's called ischemia. And if it's permanent, then we can have a myocardial infarction. It's also known as a heart attack. Here's the cardiac muscle tissue itself. Cardiac muscle tissue is going to be comprised of these cardiac muscle fiber cells. Here's one. Surrounding that, we're going to have the sarcolemma. We also are going to have gap junctions, which are going to allow us to communicate across from one cell to another. And these intercalated discs, which are going to be merging these two together. So if we take a cross section and pull apart those intercalated discs, you can see that we have these little, I don't know, bumps, I guess, that are going to fit together kind of like a nice little glove. We also have a ton of mitochondria. Again, mitochondria are going to be energy-producing cells. Really important. We're going to need a lot of energy to be continuously pumping. We're also going to need a lot of oxygen to be continuously pumping, which is why we have our own blood supply. Here, if we look at one cardiac muscle fiber, this is going to show you all of the components of that. So here we have, and when we talked about the muscle fibers itself, we talked about how the contractile tissue worked, but this is just kind of an overview. Basically, what happens with it is we have the thin and the thick fibers. Here's our thick fibers. That's myosin, the thin filaments of actin. That thin filament is connected to the Z disc. The thick filaments are connected to the M line. And if we have contraction occurring because the myosin and the actin pull each other together, this will get closer to the Z disc, right? The thick filament will get closer to the Z disc, and the thin filament will get closer to the M line, and we'll have more overlap, essentially. We have these regions that surround the whole thing that are going to be the transverse tubules of the sarcolemma. We also have the sarcoplasmic reticulum here, which serves to have fluid exchange across this entire region. And as I mentioned, we're going to have a ton of mitochondria, and these are going to be multinucleated tissues, so we're going to have multiple nuclei per cell. But in comparison to skeletal muscle fibers, they're unique in that the cardiac muscle fibers are shorter in length but longer in diameter, and they look a little bit square when you look at a transverse section as opposed to circular, and they exhibit branching, and that's depicted here. You can see it kind of branches off. So one cell can actually split into a branch type shape, which allows us to have nice connections when we're pulsing constantly. But we have that same actin-myosin arrangement that we have the same bands, Z discs, and different zones as skeletal muscles. So all of this will look very familiar to the skeletal muscle section that we went over when we talked about muscle. So I'm not going to go over how contraction occurs because we did that previously. But contraction occurs when the thin and the thick filaments are going to kind of pull each other together such that this region gets closer to that region and this region gets closer to that region. So that's what's going to cause contraction. Now, we have different functional networks in the heart, the atrial networks and the ventricular networks. And this is important because we have to have contraction occurring at different times. And these are going to be connected by intercalated discs. So these fibers, again, they're connected by these intercalated discs. They have both desmosomes and gap junctions that are going to allow for connection as well as communication. Let's see. So cardiac cells are what's called autorhythmic. That means that they are going to be self-excitable. So the action potentials are going to repeatedly be triggered, and each action potential is going to trigger a heart contraction. So this looks kind of like this. Basically, we need to cross a threshold in order to reach an action potential. So once we cross that threshold, then we can have the spike of that action potential occurring, then we have to have a break, then we have to reach the threshold again to cause a new action potential. And this is going to show you time in seconds. Basically, what's happening is we're going to cause a rhythm because we have an action potential, then a delay, then an action potential, then a delay. And this rhythm is going to be depicted from the sinoatrial node, which is going to be what induces this whole thing, and you'll see that in a second. And they're going to be the cells that act as the heart's pacemaker, forming a conduction system or a propagation route for the action potential as it travels through the heart muscle. And the major components are going to be the sinoatrial node, the atrioventricular node, the atrioventricular bundle, also known as the bundle of His, and myofibers, which are electrical conductory fibers called Purkinje fibers. All right, so here's basically the overview of the path that the signal is going to take. Basically, the sinoatrial node is going to fire. When that happens, the signal is going to go from both the right atrium and the left atrium, although the sinoatrial node is found in the right atrium, going to travel both atria, causing contractions, and also then, in just a minor delay, sending a signal to the atrioventricular bundle or the bundle of His. That signal is then going to be taken down through the left and the right branches to these Purkinje fibers, which are the actual electrical excitable fibers in the ventricles, which causes the ventricular contraction. All right, so we can get these signals that are going to affect that sinoatrial node, which is what actually induces the contraction. So we have signals like epinephrine, et cetera, that can change the heartbeat, but they're not responsible for establishing the fundamental rhythm. The sinoatrial node itself is autorhythmic. And if we end up with an aberrant rhythm, we can induce that rhythm to be corrected by artificial pacemakers, which are going to help restore normal rhythm. So this here shows the action potential, which shows the contraction of the contractile fibers. First, we have a depolarization event, which happens here. We have a rapid depolarization, and then we have a plateau, so we still have depolarization, but it's just sustained. This happens because we have sodium inflow, because we have the change in voltage-gated sodium channels. These are very fast. These open rapidly. After we have that open, we have calcium inflow that occurs when the calcium-gated channels open, but these are slow. So slow calcium-gated channels open and sustain it. And we also have potassium channels opening to have potassium outflow. At some point, we're going to have repolarization occurring when the calcium channels close and additional potassium channels open, so repolarization occurs. This is all known as the refractory period up until this repolarization event, because we have this contractile event that happens immediately after depolarization, and once we start that contractile event, we cannot induce another contractile event. So basically, we have this time frame when we initiate it. Once it's initiated, we cannot initiate another one. So we cannot initiate another one until we fall back under -80, which doesn't happen until here. So the entire depolarization and repolarization time frame, most of the repolarization time frame, is considered the refractory period. And this is the contractile period, which is going to occur during these calcium inflow. Right? So we're going to have an action potential that occurs here, induces a contraction. Here, that contraction is sustained until here. And this entire time frame is a refractory period whereby we cannot induce another signal. Right? We can't induce another impulse. And that's actually going to be a little bit longer than the contraction itself, because it's going to include reaching up to the plateau and coming back down from the plateau. All right, so cardiac muscle creates ATP by a process called aerobic respiration. And that happens, basically what happens is we're taking glucose, remember that's a 6-carbon molecule, we're breaking it in half during a process, the beginning part of glycolysis, whereby we're going to create 2 3-carbon molecules, that's pyruvic acid. We're also going to release ATP. Now that pyruvic acid from anaerobic respiration is going to go to lactic acid. It can also be used for aerobic respiration, whereby we can get a ton more ATP out of it, but that's not the pathway that we're talking about right now. This cardiac respiration just does the immediate cleavage of glucose, the glycolysis, that gives us 2 ATP, and then we just are going to release that lactic acid into the blood, and then we'll allow the rest of the blood supply to utilize the rest of the energy from that lactic acid, or lactic acid can also build up in tissues, etc. But basically, the heart can't be bothered to enter into the rest of the cellular respiration. Now, cardiac muscle also produces ATP from creatine phosphate, and it does that by this pathway. So ATP is going to lose its free phosphate and give it to creatine. Right? That means the creatine phosphate. Every time you see these little points, that's the higher energy form. So ATP goes to the lower energy form as creatine goes to the higher energy form. It goes to creatine phosphate. And that's all during relaxed muscle. And then when we need contraction, that creatine phosphate is going to get converted back to creatine, and the local ADP molecule can then turn into ATP for a quick ATP use for a very short duration of energy, about 15 seconds till we have depleted our creatine phosphate reserves. So if we have creatine kinase in the blood, that means that we probably have injury to our cardiac muscle, which usually indicates that we've had a myocardial infarction or a heart attack, right? So this talks about an electrocardiogram or an EKG, and these are going to be different electrical impulses that are going to accompany the cardiac cycle throughout the different things that are going to occur. So in blue, we're going to see the atrial contraction, and then we're going to see the ventricular contraction here in yellow. And this is what it should look like normally. This is what a normal slight P peak, then a depolarization for Q, a nice sharp RST, and then a nice T peak as well. And that's what a normal EKG could look like. Now, if we see different ECGs, then we might have different issues, and that will tell us which different region of the heart might be damaged. Okay, so the P wave, which is this section here, is going to correlate to the atrial depolarization and the spread of the impulse from the sinoatrial node over both atria here, and that's associated with atrial contraction, as you can see. The P to Q interval is going to represent the conduction time from atrial excitation to ventricular excitation. Basically, how long does this take from atrial excitement to ventricular excitement, right? There's a little bit of a lag time. And that's depicted here as this QRST, right? And that is going to be the beginning of ventricular excitation. That S to T time frame represents contractility of the ventricular fibers, so that's the nice long ventricular contraction here. And then T is going to be recovery. Okay, and this is what's going to be happening if we're looking at the heart itself during each of our stages. We're starting with 1. As that P comes up, we are firing the sinoatrial node. We haven't gotten contraction yet, but we're about to induce it. We get contraction just a moment later, just after that P wave. Then we end up with depolarization of the ventricular contractile fibers, right? Basically, we're popping from the sinoatrial node to the atrioventricular nerve, atrioventricular node traveling down to the those Purkinje fibers. Bundle of His is the atrioventricular node, right? That occurs here, and that's going to be denoted by a sharp QRS peak, right? Then that's going to be followed immediately by contraction of the ventricles, right? Systole. And then after that, we end up with the T wave, which is the repolarization of the ventricular contractile fibers, right? And then after that, we end up with relaxation of the ventricles, and we're going to lather, rinse, repeat by inducing contraction of the atria. Okay, so the cardiac cycle is going to consist of the contraction and relaxation of both atria, followed immediately by the contraction and relaxation of both ventricles. And again, contraction, systole, relaxation, diastole, right? So systolic pressure and diastolic pressure. This, remember we talked about, this was almost an entire PowerPoint in and of itself, talking about the different things that occur during the EKG. I think I've covered EKG itself and what happens, that we have atrial systole first, ventricular systole next, and a relaxation period. But this shows what happens in the blood pressure in the aorta, in the left atrial pressure and the left ventricular pressure. And we talked about the different major biomarkers or different major steps that are happening there, including the closing of the bicuspid valve. When that closes, that's going to drastically cause the increase, right, in our in that pressure here, right? That's going to cause a sharp increase. And then when we end up meeting the aortic pressure, then the aortic valve opens here. So here we've met the aortic pressure, aortic valve opens, aorta and the ventricle are going to increase until we decrease down to the point where the aortic pressure is going to be higher than the ventricular pressure, and then the aortic valve closes. Then we get what we call this dicrotic wave, which is kind of like a backwash. So as the blood washes backward, we end up with another pressure, and then aortic pressure will fall back to where it is to begin with. And that left ventricular pressure will fall as well until we're going to end up with the bicuspid valve opening, at which point our atrial and ventricular pressure are going to match again. So atrial and ventricular pressure are intending to match up until the bicuspid valve closes. Then the ventricular pressure is going to try to match the aortic pressure. Then the aortic valve closes. Then the bicuspid valve opens. And now we're back to matching the atrial pressure again. These are the sounds that it's going to make. Basically, these are the lub-dub Lub-dub. And then this talks about the volume in the ventricle, right? And the volume is going to increase in the ventricle until contraction. Then the stroke volume is going to release that, whatever volume is pushed out. That's called the stroke volume between the end diastolic and end systolic volume. And that's how much is going to be the output per cardiac stroke. And then we're going to fill it again until we end up with the regular, right? And then we're just going to lather, rinse, repeat that. And this is what's happening at each of those stages, which I've kind of already talked about. First, we have that atrial contraction. This is the moment when we have all 4 valves are closed. This is isovolumetric contraction. Then we have ventricular ejection. So the ventricles are going to contract, causing the liquid to go out, the blood to go out either through the aorta or to pulmonary circulation. Then again, we have another isovolumetric moment when we have relaxation and ventricular filling to follow, and then atrial contraction again. So this is the overview of the cardiac cycle from multiple different angles, including the ECG, the pressure in the ventricle, the aorta, and the atria, the sounds it makes, and the volumes in the ventricle, as well as the overall the phases of the cardiac cycle. So I know there's a lot to take in here. This is something I would go back to the PowerPoint and walk myself through, but anything on that is fair game. So the pressure and volume changes that happen during the cardiac cycle basically happen by having alternate contraction and relaxation, which forces blood to go from high pressure to low pressure, right? So if we're going to have change in pressure in the ventricle and the atria over and over, that's going to allow blood to move from one to the other. And then this is just talking about the different times. You don't need to know the exact times of atrial systole, ventricular systole, and relaxation, but this is just telling you that overall, the longest time frame is the relaxation period. So we have about 0.1 second in atrial, 0.4 second in ventricle systole. So we have contractions about the same, contraction A, contraction B is about the same time, 0.4 seconds, as the relaxation period. Okay, talks about how to use a stethoscope and what you're listening to. What you're listening to is the turbulence of the blood flow, the valve closure. So you think that you're listening to the contraction of the heart muscle itself, but you're not. You're listening to the swoosh from the blood flow happening when the valves are opening and closing. Okay, sometimes individuals can have a heart murmur, and that would be if the sound that is made by during this contraction of the valves opening and closing is abnormal, and that abnormal sound would be made because the valves are closing abnormally. So we either have abnormal anatomy or abnormal volume of flow. Not all murmurs are going to be abnormal, but most of them do indicate that we have some sort of valve disorder, so it's not working as well as it could. That doesn't necessarily mean that it's a symptom of anything larger. It just might mean that you're an individual that has an abnormal valve setup. We talked about cardiac output being comprised of 2 major things, including stroke volume and stroke and heartbeat or heart rate. And the amount of oxygen carrying blood that is sent out from the heart is known as cardiac output. And we need more cardiac output if we are going to have extreme exercise, for example, or hypoxic conditions. And so this is why your heart is going to pump more when you are exercising or when you've just had a fight or flight kind of response. So again, cardiac output is defined as the volume of blood ejected per minute into the aorta from the left ventricle, and it's going to be equal to the stroke volume multiplied by the heart rate, which is the number of beats per minute. And we can regulate both of these. So we'll talk about regulation of stroke volume first. So stroke volume can be regulated by 3 factors: the preload, the degree of stretch in the heart before contraction, and the contractility. So the preload is basically going to be the effect of stretching. So the greater preload, or the stretch of the cardiac fiber muscles just before contraction, increases the force of contraction up until a certain point, obviously, during that systole or the contractile event. And the Frank-Starling law basically says that the output of the right and left ventricles keeps the same volume of blood flowing to systemic and pulmonary circulation. So the same amount of blood is flowing into the lungs as is flowing into systemic circulation and feeding the rest of the body. Now, contractility is the actual strength of the heart during the contraction, and it can be affected by a couple of different things, including positive ionotropic or negative ionotropic agents. And if we have a constant amount of preloads, the preload hasn't changed at all. The stroke volume will increase if we have positive ionotropic agents and decrease if we have negative ionotropic agents. And lastly, we have afterload, which is the pressure that has to be overcome before the semilunar valve can open. And if someone who is facing something like congestive heart failure, for example, we're going to end up with blood pooling in the ventricles and remaining in the ventricles, which increases the preload and causes overstretching of the heart. And eventually, overstretching of the heart leads to less forceful contractions. All right, so I was talking about, previously that was just talking about stroke volume. Now we're going to be talking about regulation of heart rate. Now we can change heart rate by a couple different mechanisms. We have short-term control and also a little bit longer control as well. Most of the factors that are going to contribute to regulation are going to be autonomic. So autonomic regulation of the heart is going to involve input from a couple regions, either your brain sensors, including your hypothalamus, your limbic system, your cerebral cortex, etc., are all going to tell you whether you need to increase or decrease your heart rate. And then we also have sensory receptors, like proprioceptors, which are going to tell us where we are relative to our surroundings and monitor the movements of things around us. Chemical receptors, which monitor the chemistry of the blood, so they would know whether we have low oxygen conditions, for example. And baroreceptors, which monitor the pressure of the blood. And that's going to be constantly sending information to this cardiovascular center, which is then going to send information out to the heart via the cardiac accelerator nerves if it is following the sympathetic or fight or flight response. And if we're following the parasympathetic or rest and digest responses, this is going to go out through the vagus nerve. And they're going to result in opposite output. So the sympathetic system is going to increase the rate of depolarization, so increase the heart rate, whereas the vagus nerve is going to decrease the rate of the depolarization and therefore decrease the heart rate. All right, so other factors that are going to involve your heart rate are going to include things like age, your gender, your level of physical fitness, and also your temperature. And this figure here just basically summarizes pretty much everything I just told you. So we have, in terms of stroke volume, we have preload, contractility, and afterload. So if we're able to increase the stretching to begin with, then we're able to increase the amount that is going to be ejected. If we can increase the contractility, we can increase the amount that is ejected. And if we can decrease the afterload, right, how much is left, then we can increase the stroke volume. So all of these factors lead to increased stroke volume. And increased heart rate can be affected by your nervous system, your chemicals that are present in your blood, and other factors like your age and your sex and your physical fitness level and body temperature, etc. And that leads to heart rate and stroke volume is going to increase or lead to cardiac output. So if we have increase in either of these or increase in both, that will increase cardiac output. All right, so when we exercise, it's going to increase our heart rate because our oxygen demand in the muscles is going to drastically increase, and that means that the circulation is going to have an increased demand from the heart. So if we undergo aerobic respiration, aerobic exercise multiple times a week, we can increase our cardiac output and also increase our HDL, which is our good cholesterol levels, decrease our triglycerides, improve our lung function, decrease blood pressure, and have our weight under control. So aerobic exercise is very good for the individual for a lot of different reasons. Okay, so this is going to talk about failing hearts and different methods of, or levels, I suppose, of a transplant. So this is going to be a half donor transplant whereby the left atrium is sutured. So we're only going to be taking a donor left atrium. It's going to be sutured directly to the recipient's left atrium, and that's going to then, we're going to then connect the blood flow to the donor heart and away from the recipient failing atrium. Now, here we're showing the right atrium sutured to the recipient. So here's a donor right atrium sutured to recipient superior and inferior vena cava. So we're basically just going to be using the donor heart instead of using the recipient's heart. We're not going to remove the heart because we're still going to be using the other parts of it. We're only going to be basically adding on an additional atria, and we're going to be putting the blood flow into this atria instead. Right? And this is an entirely transplanted heart, whereby we have removed the heart and put a new heart in. The development of the heart, I'm not going to test, but I did leave in case anybody had interest, but I won't spend our time on it now. Only thing of interest here, again, this is not tested, but we do have that fourth, we have a fourth region that branches off of the aorta, and we have a septum in between the atria, in between the left and the right atria, that's eventually going to close off and become this foramen ovale. Okay, so that is going to cover the heart. Do we have any questions on that before I move on to circulation?
Not of right now. Actually, I had a question about the QRS complex.
Sure.
So, the QRS complex is essentially when
You want to use this one?
ventricular contraction will begin, right? So then,
It's
from
the
what I understand,
initiation of it, but it actually happens a moment after that. So here's
okay,
ventricular contraction. It occurs like at the, so you see what I mean? So Q actually is right before, and then ventricular contraction. So most of it is ventricular contraction, but it's also the initiation of the contraction. Does that make
okay,
sense?
so QRS is essentially the initiation of the contraction, and then
And
the
the contraction
ventricular
itself.
contracts,
Yes.
and that's the
So
ST
let me go up
segment
just a
that
little bit
kind of
further and tie
plateau.
it back to this. So this right
Okay,
atria, the sinoatrial node, is firing, and then that's going to be picked up at the atrioventricular nerve, or node, sorry. And that atrioventricular node has to pass that along down into these Purkinje fibers. So what you're seeing is both the initiation of that atrioventricular node, so the receipt of the signal, as well as the delay and then the contraction. Does that make sense?
oh, got it.
So
There's a
this little bit right
delay.
here, the signal is still being received, right? And then it gets
Right,
contracted. And even after the
got
signal
it.
is received, we're still, so this electrical signal has already passed, but now, even after we're recovering, we're still having contraction because the Purkinje fibers are still being told to contract. Does that make sense?
Okay, got it.
So you're kind of trying to
It
tie
most
along
definitely makes sense.
what's happening with the electrical signals as well as the timing to form those contraction. So the contraction isn't instantaneous, right? We have to have the electrical impulse travel and then it's going to happen.
Got it. Thank you.
Yeah, so the QRS complex starts, that's basically happening when we're hitting that AV node, traveling down, and then the Purkinje fibers contract, and then that happens right about maybe the beginning of R. But after R, we've already gotten our signal. The signal's already been passed on. It's relayed. So now it's just restoring, but we're still going to have the contractile event occurring. And then we end
Because
up with
the Purkinje
relaxation.
fibers think they're contracting.
So the ventricular contraction occurs for a little
Okay,
bit longer. So the impulse is the signal up is the impulse. Then we're just going to have restoration of that impulse to here, but we're still having contraction at that time frame.
got it.
And that correlates with, so that QRS correlates with the contraction of the ventricles, whereas this part correlates with the contraction, or is the initiation of the contraction for the atria.
Okay, got it. Thank you.
You're welcome. All right, so let's move on to circulation. I know there's so much here. I apologize. We're already at the hour and a half mark, and we're only 2/3 of the way through. All right, so circulation basically is going to be discussing hemodynamics, which is how blood is going to be altered as it moves through the body, and also how blood pressure is regulated as the blood travels through the body. And again, we'll also be talking about the anatomy, right, or the histology of the blood vessels, and the anatomy of the arterial and venous systems as well. So this shows both the arteries and the veins. They all have the three major regions are the same. So the tunica interna is the innermost part that's going to line the lumen. Then we have layers of basement membrane, and we have elastic lamina that occurs only in the arteries. We don't have the elastic lamina in the veins, and that's because arteries are going to be under arterial flow, so they're going to be kind of pulsing a little bit, whereas veins are just going to be venous return. It trickles in. We don't have any. There's no need for stretching. But the three major regions, the interna tunica, the media tunica, and the externa tunica, and that's going to be the same for both arteries and veins. So again, the major differentiating factor would be these elastic lamina found in the arteries and these one-way valves that are found in the veins. Now, capillaries, which are going to be the connection between the arteries and the veins. We have arteries, arterioles, capillaries, venules, then veins. So these capillaries have an endothelial layer and a basement layer, and then of course a lumen through which the blood is going to travel. And there's multiple different types of capillaries that get progressively leakier as we are losing things to the external environment or to the interstitial fluid. So again, internal, media, and external are the three major layers. Blood vessels are created by the process of angiogenesis. Cancer cells do this quite often. They are going to need to have a larger blood supply because they're basically making their own city where there oughtn't be a city, so they need to bring in all the pipes to feed that city. They're basically making a ton of cells where they aren't supposed to be making a bunch of cells, and one of the things that they need to feed those cells, obviously, is blood supply. So anti-angiogenesis drugs are all the rage for cancer treatments, or at least for slowing cancer down. All right, so as I mentioned, arteries are going to be what takes the oxygenated blood away from the heart and delivers the oxygen to the tissues. Three major layers, again, the interna, which is going to go right against the lumen, that should be found here, the media, found here, and the tunica externa, found there. And the reason that you see it all kind of bundled like that is because arteries are elastic. The elasticity, which happens based on that elastic layer that I just talked about here, right, this elastic lamina, that elasticity is very important because it's going to have to be responding to the pulse of blood coming out of the heart. And the elasticity is going to vary based on how close we are to the aorta. We have elastic arteries, which are specialty arteries that have more elastic fibers and less smooth muscle fibers. And these are going to be able to take the blood that's under pressure and propel it onward. They're also sometimes called conducting arteries because they conduct blood from the heart to medium-sized arteries. These are also forming pressure reservoirs because when the aorta is going to be receiving blood from the ventricle, we're going to have expansion occurring, right? We're going to have a surge of blood, and then it's going to have contraction occurring after that blood flows out towards the capillaries. And so these guys have to have that elastic lamina because they have to be able to stretch and contract every time that we have the aorta pulsing, basically, because of the contraction of the ventricles. We also have muscular arteries. Now, muscular arteries have more smooth muscle than elastic lamina. That doesn't mean they don't have elasticity. They just have less elasticity. And their responsibility is going to be to distribute blood to various regions of the body. Anastomoses are going to be anytime that we have branching or union of the branches of arteries, and this is going to be similar to if you're driving through your neighborhood and you have someone stopped in front of you and you're not going to be able to get around. You're able to back up and go around the other way because there's always another route to get to your house in a neighborhood. That's the same thing with the anastomoses. These are going to be alternate routes for blood to reach a tissue or organ. And that's going to allow for alternate blood flow routes through these anastomoses, right? And anytime an artery does not have an anastomosis, that means it does not anastomose, these are called end arteries. And if they get occluded or blocked off, that's going to disrupt blood supply to that entire region, which causes necrosis or death. So if we're able to get around this, obviously we don't want necrosis to occur. If we're able to take an alternate route to feed that tissue through those anastomoses, that's obviously better. Occasionally, anastomosis can consist of two veins or a vein and an artery as well. So anastomoses are just going to be junctions of the vasculature. Now, arterioles are smaller arteries. They're almost microscopic. These are going to regulate blood flow to the capillaries. They do that through vasoconstriction and vasodilation, so constriction and dilation of the blood vessels, which allows for more or less blood flow. And that allows them to have a pretty major role in regulation of blood flow from arteries into capillaries, which also is going to help alter the arterial blood pressure. From arterioles, we're going to go into capillaries, and capillaries are microscopic. These guys are generally going to be about thick enough for one blood vessel to go through at a time, and they're going to connect an arteriole and a venule. Here's an example. Here's red blood cells. As you can see, there's only one red blood cell thickness. So this is one of those regions I told you blood had a bunch of turnover. That's because these capillaries are constantly squeezing the red blood cells, so they're brushing up against the capillary, which means they're ending up with friction occurring, essentially. Now, blood through capillaries is called microcirculation, or circulation at the tiniest level. And capillaries are found next to almost every cell in the body. But depending on the metabolic needs of that tissue, we end up with more or less capillaries that feed those tissues. Now, as I mentioned previously, the primary function of capillaries is to permit nutrient exchange of nutrients and waste between the blood and tissue cells. So basically, the blood delivers things to the interstitial fluid, and the interstitial fluid delivers things to the cells, and then the cells deliver things to the interstitial fluid, and the interstitial fluid delivers it back to the blood. So this is how we're delivering things like oxygen and retrieving things like carbon dioxide and cellular waste. Now, capillary walls are very thin. There's a single layer of cells called an endothelial layer and a basement membrane that surrounds that. And this is going to form an extensive capillary network throughout all of the tissues. And that allows us to increase the surface area, which means that we're able to exchange more materials to the tissue. And we can regulate the blood through the capillaries by these specialty smooth muscle sphincters. So here we have blood flow from the heart and the arterioles getting through the capillary bed into the venules. And this shows it open or relaxed where everything is able to come through. The blood flows through all the capillaries. And here, if we need to have just a direct blood flow, we will eliminate blood flow to these extra regions and have direct blood flow through the capillary to the venules. And that happens when we have the sphincters contracted. And basically, we're at this point, we're saying that this tissue doesn't necessarily need as much of a blood supply as it might when these are all open. So when, say, you're exercising and everything's flush, it's because the tissue is using all of that oxygen and therefore needs to have all of the circulation. So we end up with more blood to that tissues. All right, so let's look at capillaries. We have three major types of capillaries, and basically they get holier as we go along. So this is a continuous capillary bed. We do still have some little slots here, these intracellular clefts. We also have penocytotic vesicles. So let's talk about penocytosis for a second. Penocytosis is a way by which we can pull in, it's called cell sipping. We can pull in small amounts of fluid from either the extracellular fluid or whatever it is. So we can engulf certain pieces and bring it in, or it can leave. So these vesicles then can secrete fluid from the blood plasma as well, right? Here we're showing also nucleus of the endothelial cell. These guys are going to be the tightest capillaries, the continuous capillaries. These are going to lead into fenestrated capillaries, which have these fenestrations, as you can see, these pores. So we also not only have the penocytosis occurring, but now we have leakage through like a sieve, these fenestration regions. And if we go even further, we have what's called sinusoid cavities. And these guys are so leaky that the only thing that comes through here, the only thing that's not going to be allowed out, is going to be our red blood cells ourselves. We have an incomplete basement membrane. We have giant holes or sinusoids in between the endothelial cells and the extracellular tissue. So these are basically, we have the intracellular clefts that we saw previously. We have penocytosis, and we also here have fenestrations there and sinusoids here. All of this is going to allow for leakage to occur, right? Then these capillaries are going to interact with venules. Venules are small veins. Multiple capillaries come together to form these venules. Multiple venules come together to form veins. And this is going to be a drainage of blood. And drain is the right word. We're no longer under pressure. This is like kind of a nice leaky, slow drainage into the veins. Veins are going to have those three major layers, right? Interna, media, and externa tunicas. But they have less elastic tissue by far and thinner walled than the arteries. They don't need to be thick because they're not under pressure. And they have those specialty one-way valves. So this is the same image that I showed you earlier, but now I'm going to focus on the one-way valve here, because this is important. Nothing's happening by pressure. So previously in arterial flow, the blood's flowing because it's being pushed along. Here it's kind of being sucked along from the vena cava, being pulled into the right atria, but it's also being propelled by like skeletal muscle pumps, etc. So that means is that as the blood flows through, we want to have stop points where it can't go back any further. You can picture like an airport where you can only travel in one direction, but you can't turn around and go back out the way that you came, right? So you're only able to go through these one-way valves. And that's going to result in the blood being propelled in one direction, but it also means that we can have pooling occur where the blood settles back down on top of these valves until it's going to be pushed forward by like the skeletal muscle mechanism or something like that. Now, venous sinuses are going to be veins that have very thin walls with no smooth muscle, and these are going to be regions like the coronary sinus of the heart, for example, but we also have this in the brain, like the sagittal sinuses of the brain. Now, if we end up with weak valves, we can cause what's called varicose veins or just pooling of blood. And varicose veins appear blue or purple because it's deoxygenated blood and venous return, so it's going to be a darker because remember, we're only going to be getting that nice red color when we have the iron interacting with oxygen to give us the rust color. Most of the time, we're going to be having a nice, we never really get blue, but a nice deep purple. So most of the blood in circulation at any given moment is going to be in the veins and venules. These are called your blood reservoirs. I think it's 60% of the blood or so that's going to be found in the veins and venules. And if needed, they're able to undergo vasoconstriction and move that blood to other parts of the body. And sometimes this vasoconstriction in the veins is going to help compensate for blood loss, particularly in the case of a lot of blood loss, like a hemorrhage. We also have blood reservoirs in the abdominal organs, such as the liver and the spleen and the skin. And so if need be, the liver and the spleen can contract and force back out blood cells that were either targeted for cell death and were about to be degraded back into circulation, etc. So let's talk about what happens in the capillaries. In the capillaries, we have exchange of substances. Things are leaving and entering the capillaries by way of diffusion and transcytosis and bulk flow. So diffusion would be happening across the membrane. That's basically going to be happening via simple diffusion. Things like oxygen, carbon dioxide, sugars, amino acids, etc., are all going to diffuse down across their concentration gradients, so from high to low concentration. And then anything that's a solute in the plasma that's not very large, so not large proteins, can pretty much pass freely across the capillary walls. Um, so the exception of diffusion is going to be inside the brain, where we have a blood-brain barrier. So certain pharmacological drugs need to overcome the blood-brain barrier to be able to get into the brain. We're also going to have a blood-testes barrier that's going to be very similar to the blood-brain barrier. Additionally, we can have things entering into and exiting via transcytosis, which is where things are going to be enclosed in tiny vesicles that enter by endocytosis. Remember, I was talking about penocytosis, like cell drinking. Well, now we can also have it via endocytosis, where we're pulling in larger molecules through this vesicular exchange. And last but not least, we can also have bulk flow, which is going to happen through those fenestrations and sinusoids, where diffusion is going to be the most important part for the plasma and interstitial fluid. Bulk flow is the most important factor for regulation of volumes of these blood and interstitial fluid. So the bulk flow is where the volume is going to be exchanged. And the movement of the water and also the dissolved things, like the protein, everything except proteins, I mean, is going to be dependent upon different types of pressures, basically pressure out and pressure in. So those are called hydrostatic and osmotic pressures, and that looks like this. Okay, osmotic pressure would be out, hydrostatic pressure would be coming in, and it's always going to be a net pressure of the hydrostatic pressure and the osmotic pressure. So here's the blood hydrostatic pressure and the interstitial fluid osmotic pressure, and here it's the blood coagulate osmotic pressure and the interstitial fluid hydraulic pressure. But basically, how much is the blood pressing outward versus pulling inward, right? And those two pressures are constantly going to allow things to escape and also to come in. And here we're also showing the lymphatic tissue. As you remember, certain things like fat globules are going to need to travel through the lymphatic fluid. So things are going to be picked up by the lymphatic fluid and also be released into the interstitial fluid and then back into the blood plasma. So we're going to be constantly having a crosstalk of things that are going to be going into and out of the blood supply, into and out of the lymphatic fluid, as well as into and out of the interstitial fluid, which then will then be going into and out of the cellular fluid. And that all occurs based on the pressure in and pressure out, right? Hydrostatic pressure, again, that's going to be the pressure out, blood hydrostatic pressure. And the osmotic pressure is the pressure inward. And based on these pressures, we're going to end up picking up or releasing bulk volume of fluid as well as particular solutes in the fluid. Okay, now if we end up with a disruption of filtration and absorption, we can end up with an increase in interstitial fluid. So if we end up with too much interstitial fluid, that's called edema or swelling. This occurs if we have injury to the sites or if we just have issues with the actual filtration. So if we end up with kidney issues, for example. But if we have issues with the filtration and resorption between the interstitial fluid and the blood plasma, again, that causes something called edema. And edema is basically when we have abnormal levels of the hydrostatic pressures and the osmotic pressures. So when we have a change of those pressures, it's going to allow a greater amount of proteins, etc., to leave the blood and enter the tissue fluid, and less of it to come back into the blood supply, which ends up retaining fluids and causing a blockage of lymphatic vessels. So it can be due to certain things, as I mentioned previously. It can be due to injury, but it can also be due to infections such as filarial worm infections. Okay, so blood flow is dependent on multiple different factors, and how all of these factors interrelate with one another is called hemodynamics. That's hemodynamics. And that actually is going to be dependent on the distribution of the cardiac output to different tissues. Depends on the interplay of all of these factors that are going to drive the blood flow and resist the blood flow. And blood pressure is basically how much pressure is exerted on the inside walls of a blood vessel. And in general, we're going to be looking at the pressure in arteries. Why? Because venous return doesn't really have very much / any blood pressure at all. Okay, so we talked about cardiac output, and we talked about what that meant in terms of stroke volume and heart rate, but it also can be broken down into the aortic blood pressure divided by resistance. So how much blood is being pushed forward versus how much resistance is pushing backwards. And factors that affect that blood pressure involve cardiac output, like I mentioned, blood volume, viscosity, the resistance, and also the elasticity of your arteries. So how much can your artery stretch to allow that blood to be able to be accommodated? As soon as blood leaves the aorta and flows through systemic circulation, its blood pressure is going to fall by the time it reaches the right atrium and is pulled back in via the vena cava, right, etc. Then it's going to be almost zero. So here we have the blood pressure. This is your regular lub-dub that you're seeing with your systolic and diastolic blood pressure, systolic being high, diastolic being low. And that's going to happen as we travel through the arteries. We're not losing anything into the arteries. As we travel into the arterioles, we still haven't lost anything, but we're going to have a little bit of reduction in that. This is going to be more the muscular and less elasticity. And then as we enter capillaries, we're going to start losing blood volume into interstitial fluid. And then as we enter into venous return, we're just going to have trickling back, basically. So we're going to end up with very low blood pressure by the time blood reaches the right atrium. And that's why blood pressure is depicted as arterial pressure and obviously not venous return. Now, when I mention resistance, that refers to the opposition or how much pressure is coming back in resistance to blood flow, typically resulting from friction between the blood walls and the blood vessels, right? So blood in the walls of the blood vessels. Vascular resistance depends on a couple of things. How wide is the blood vessel? How viscous is the blood? So how thick is your blood? And how long is the total blood vessel length? And we also can have systemic vascular resistance, which is known as the peripheral resistance. And this is all of the vascular resistances combined by all of your systemic blood vessels. And you'll notice that most of the resistance is found in the arterioles, capillaries, and venules. Why? Because these are the smallest blood vessels. Now, venous return occurs because now we have a pressure gradient between the venules and the right atrium. The right atrium is going to have kind of a suction effect on the venules. And it's going to be maintained, like I mentioned, by that suction, the pressure changes associated with the breathing and rhythmic contractions of the heart, but as well as skeletal muscle contractions and the valves in the veins. So this is an example of what's happening. So when I said previously that deep vein thrombosis is something that can occur and that you want to make sure that you have regular exercise to kind of stave it off, this is what's going to help stave off deep vein thrombosis, or the accumulation of clots in those deep veins of the lower limbs. So basically what happens here, we have two different valves in a vein that the blood is going to be sucked in, and then when we have compression occurring, that blood is going to get forced, but since it can't go backwards because of the one-way valve, it's going to get forced outward. And every time that we do this, we're going to then suck in more blood and force that blood outward. And here, when this relaxed, the blood's going to try to come this way, but it can't because of that one-way valve. So you can see the blood's going to constantly get forced upwards until it finally is going to enter into the vena cava. So the blood flow is going to be something that's going to be determined as the amount of blood that flows through any given tissue in any given period of time. And the speed of that blood flow is going to be related, specifically inversely related to the cross-sectional area of the blood vessels. So the blood flow is going to be the slowest when the cross-sectional area is the greatest. And that means we're going to have the most resistance. And so this is basically showing you the blood flow, that how it's going to decrease as we leave the aorta and into the arteries and into the arterioles until we eventually at the capillaries we're going to lose pressure almost entirely, right? Because we've got the sinusoids. And then as we're going to have venous return, we're going to increase our blood velocity again, right? And here this is showing you the cross-sectional area of the aorta versus the arteries versus the arterioles, increasing the most of the capillaries, decreasing again the venules until we reach down into the veins and then the vena cava. So again, inversely proportional. The velocity is inversely proportional to the cross-sectional area of the walls of the vasculature. So here we are summarizing the factors that are going to affect blood pressure. So things like blood volume, the skeletal muscle pump, the respiratory pump, and venoconstriction all are going to increase your venous return. Your venous return and different sympathetic impulses and hormones are going to result in an increased stroke volume. Those sympathetic impulses and hormones also play a role in heart rate, as do parasympathetic impulses. So if we have less parasympathetic and more sympathetic, that's going to increase our heart rate. And as you know, heart rate and stroke volume are going to be involved in cardiac output. And cardiac output and systemic vascular resistance are going to lead us to mean arterial pressure. So let's talk about vascular resistance. So the number of red blood cells, as well as that's going to lead to the blood viscosity. Blood viscosity and blood vessel length are going to be involved in systemic resistance. So the body size can relate to the blood vessel length. So if we have obese situation, now we have an increase in blood vessel length, means we have an increase in systemic vascular resistance. Additionally, the blood vessel radius, or if it decreases under vasoconstriction, can increase our systemic vascular resistance as well. And again, cardiac output and systemic vascular resistance are the two major players in mean arterial pressure. All right, so I feel like I mentioned this earlier. I just didn't really realize that it was going to be here. So here's how we're controlling our blood pressure and our blood flow. I mentioned previously the cardiovascular center. The cardiovascular center is going to be receiving input from several regions, including receptors like proprioceptors, baroreceptors, and chemoreceptors. Also from higher brain centers like your cerebral cortex and your limbic system, etc. That's all going to get sent out through the cardiovascular center. Parasympathetic nerves are going to carry the parasympathetic output through the vagus nerve to cause a decreased heart rate. Sympathetic nerves like the cardiac accelerator nerve are going to increase your heart rate and contractility. And then vasomotor nerves, also of the sympathetic pathways, are going to cause vasoconstriction of your blood vessels. So output from the cardiovascular center is going to flow along both the sympathetic and the parasympathetic fibers, which are going to cause opposite reactions. And again, this is basically just showing similar things and how they work. So input is going to come in from baroreceptors, such as the ones that are found in the carotid sinus and in the arch of the aorta. That's going to send through the cardiovascular center, and it's going to have effectors that are going to be triggered by the vagus nerve and the parasympathetic pathway. That's going to reach the sinoatrial nerve and the sinoatrial node, and the atrioventricular node. Both of those are involved in contraction, right, of the atria and the ventricles. And here we're showing the motor neurons that are the efferent neurons in the sympathetic pathway that are going to cause opposite effects in the sinoatrial and the atrioventricular nerves. The parasympathetic are going to slow these two. The sympathetic are going to increase the rate of these two. And additionally, the sympathetic has an added bonus of being able to innervate the ventricular myocardium and cause stronger ventricular contractions as well. So it can increase your heart rate as well as your contractility. Whereas your parasympathetic is only going to be able to affect the heart rate itself. And again, it's going to do that by decreasing it. Let's see. We talked about how blood pressure is regulated. So we have baroreceptors, again, in the cardiac sinus as well as in the aortic arch. The cardiac sinus is going to be responsible for maintaining blood pressure in the brain and the carotid sinus. The aortic reflex is concerned with the systemic pressure in the general circulation, basically. And it's initiated, again, by baroreceptors that are found in the arch of the aorta or attached directly to the arch itself. And if blood pressure falls, then we end up with this feedback loop. So again, any feedback loop occurs because we have a disruption in a controlled condition, in this case blood pressure, that occurs by some sort of stimulus that's going to disrupt homeostasis. In this case, we're disrupting blood pressure. That's going to be detected by baroreceptors. These are pressure receptors that are found, again, in the carotid sinus and in the arch of the aorta, which then sends information to the cardiovascular center, which is found in the medulla oblongata. I'm never going to quiz you on that, but it also sends information to the adrenomedulla, where we're going to secrete epinephrine and norepinephrine. And again, that cardiovascular center is going to increase the sympathetic and decrease the parasympathetic pathways. The effects of those are going to be the heart and the blood vessels, where we're going to increase stroke volume, heart rate, and increase cardiac output. We're also able to increase our cardiac contractility. And here we're going to be able to also constrict our blood vessels, which is going to increase our vascular resistance. All of that's going to increase our blood pressure. Hopefully that'll return to normal, where we're going to no longer need to have this pathway occurring. All right, so we talked about hormonal regulation of blood pressure, such as angiotensin 2, epinephrine, norepinephrine, antidiuretic hormone, ANP, and how these guys affect blood pressure and blood flow. I did not put this table here, but if you don't have any idea what I'm talking about, you should go back to the PowerPoint or to your textbook and just overview what these different hormones do and how they regulate cardiac output by either changing certain things, right? Changing the blood volume, changing the overall cardiac output, changing the systemic vascular resistance, etc. And blood pressure is under autoregulation, which is important because we want to make sure that the tissues get the amount of blood that they need. So the tissue is able to adjust the amount of blood flow to match metabolic demand so that the supply of O2 and nutrients is going to meet the needs of the tissue. That's called autoregulation. And the stimulus of autoregulation is going to be the concentration of oxygen in those tissues. All right, so how do you check your pulse? This we've talked about. A pulse is basically going to be the expansion and recoil of the artery wall that happens with each heartbeat. It happens in every artery that lies near the surface. It happens in every artery, but you're able to detect it in any artery that lies near the surface or over a hard tissue, and it's found strongest in the arteries closest to the heart. Oftentimes we use it in the radial artery, and that's going to be found in the wrist, right? But we can also detect it in the carotid artery or in other regions like the femoral artery, etc. Now, a normal heart rate is between 70 to 80 beats per minute. And if we have tachycardia or bradycardia, that means that we have a much higher pulse or a much lower pulse. So we're out of our normal range by being either too high or too low. Now, again, we measure blood pressure by blood pressure cuffs, and those of you that have joined us in lab have had the chance to play with these already. We'll be playing with them next week as well, so don't worry if you missed it. You can do that next week too. But the blood pressure cuffs basically go on, and along with that, you also have a stethoscope, and you're able to record the force where you're last hearing the sound, i.e., you have collapsed the vein. Sorry, you've collapsed the artery when it is at its highest pressure, and then you release it until you hear the lowest sound. Therefore, you have you have released the artery at its lowest pressure, and that's going to give you your systolic and your diastolic, or your highest and lowest pressure of your blood pressure. Again, diastolic is the force of blood recorded during the ventricular relaxation, whereas systolic is the force of blood recorded during ventricular contraction. All right, normal blood pressure is approximately 120 over 80, but this can vary depending on whether you've just been exercising, your levels of stress, or your health levels as well. Pulse pressure is going to be the difference between the two, and that's normally about 40. So basically, you're going to be subtracting whatever you have as the top over whatever you have as the bottom, right? Subtract those two, and that's going to give you your pulse pressure. And that's going to help us provide arterial information, so whether or not your arteries are healthy. Okay, so next we're going to move on to talk about shock. And when we think about shock, most times students have a hard time with the correct definition of shock because basically what they say is low blood supply. And that's true, but really, shock happens when the cardiovascular system is unable to meet the metabolic demands of the cells. And this can happen for a couple of reasons. So we have major types of shock, including hypovolemic, low blood volume, cardiogenic shock, when the heart is functioning abnormally or is poorly. Vascular shock is what happens when your blood is not flowing properly through your vasculature because we have inappropriate vasodilation. Or we can have obstructive shock, where something is obstructing blood flow, like a tourniquet or something like that, right? And we have several different homeostatic responses to shock. They're going to include activation of multiple different pathways, including the renin, angiotensin, aldosterone systems, the antidiuretic hormone systems, which makes sense because antidiuretic hormone is involved in retention of water. And if we are losing a lot of blood, we want to make sure that we're retaining as much water as possible to help get that volume back up. Also, we activate the sympathetic division, so the fight or flight response of the autonomic nervous system, and local vasodilation can occur. Okay, so this is a pretty complex feedback loop, but basically what happens, again, we're going to disrupt a controlled condition. In this case, blood volume and blood pressure are going to drop. When that happens, the receptors that are found in multiple regions, including the ones we just talked about in the carotid sinus and the arch of the aorta, as well as ones that are found in the kidneys, these are going to have effects. So the kidneys are going to increase the secretion of renin, and the baroreceptors are going to decrease the rate of nervous impulse, which is then going to lead to changes in the control centers, such as the hypothalamus and posterior pituitary, and the cardiovascular center in the medulla oblongata. Let me start with the pathway of renin. So if we're going to have increased secretion of renin, that goes to the liver and the lungs and converts it to angiotensin 2. The effectors of angiotensin 2 are going to be the adrenal cortex, whereby aldosterone is going to be liberated. Aldosterone is going to go to the kidneys and then play a role in conserving water and salts, which is going to help increase our blood volume. Also, the ADH, which is going to be secreted by the posterior pituitary, is going to increase in our blood going to the kidneys, also resulting in a response increasing the blood volume by conservation of salt and water. And the effectors are going to include the blood vessels, which are going to undergo constriction, which is going to lead to an increased systemic vascular resistance. Um, my daughter is blowing on my belly right now. I apologize. That's what you're hearing. Okay. Hey, babe, stop. All right. So additionally, the cardiovascular center from the medulla oblongata can lead to increased sympathetic stimulation and hormones released from the adrenal medulla, leading to increased heart rate and contractility, leading to the increased blood pressure. So hopefully all of these can restore homeostasis. Unfortunately, for something like hypovolemic shock, we probably are going to have a hard time returning to homeostasis until we actually have some sort of medical intervention. So this might be something that's going to continue to try, but never actually restore homeostatic conditions. Some of the signs and symptoms of shock include clammy skin, cool skin, pale skin, as well as tachycardia, a weakened or a rapid pulse. So usually it's very weak, but it's very fast. It can also result in sweating and hypotension or very low blood pressure. And this generally is going to result in altered mental status because we're going to have low oxygen getting to the brain. Also decreased urinary output, right? Because we're conserving salt and water balance. When we conserve salt, water follows. That means the water is going to stay in the body. Means we're going to be extremely thirsty probably because we have low blood volume. We want to restore that. And also blood acidity as well, or acidosis can occur. So those are all signs and symptoms of the shock response. Okay, so now we're going to move on to circulatory routes. And this is what we're going to focus on for quite a while. There's a lot of different circulation that occurs in the body. We have systemic circulation that's going to go out to the head, neck, limbs, right, upper and lower limbs. We have pulmonary circulation, which is going to be basically where we're taking the blood from the heart out to the lungs, getting oxygenation and sending it back to the heart. And we have coronary circulation, which is not depicted here, which is going to service the myocardium. So we have a ton of different circulatory routes. And this just kind of shows an overview. So we have the systemic circulation of the head, neck, and upper limbs, which is going to be separated from the systemic circulation of the abdomen, right? Here we have the major trunks including the celiac trunk, the splenic trunk. We're going to have gastric trunks, etc., mesenteric, inferior, and superior mesenteric trunks. Then we split into the iliacs. Those iliacs are then going to feed into the lower limbs via the femoral, etc. So that's going to be our largest circulatory route, systemic circulation. But we also have hepatic portal circulation, which feeds into the liver and allows for blood filtration. Pulmonary circulation, which again is going to feed out to the lungs. Coronary circulation and fetal circulation, which we will discuss but is not tested. So again, systemic circulation is when we are taking oxygenated blood. Again, that's going to come from the left ventricle out to the aorta and travel to all the different parts of the body. Now, that's also going to include lung tissue, but not supplying the air sacs of the lungs themselves. Okay, don't touch that, baby. That's glass, okay? And that's going to deliver the deoxygenated blood back into the right atrium. All right, so this is showing the arterioles, or the arteries of the body. That's going to include, here's the internal carotid artery. That's going to allow us to have blood flow up into the brain. The aorta is going to have three major arches. Do not touch that. Do not touch that. Going to have three major arches. Again, we talked about that, including the brachiocephalic trunk, the subclavian, and then here's the carotid as well. No, please stop. Okay, so as we're traveling down, let's just start. Let's start off with the first arch of the aorta, and that's going to be the brachiocephalic trunk, and that's going to turn into the right subclavian and the right brachial. It's also going to branch off into the right common carotid, and the common carotid is going to split off into the internal and external carotid. The next branch is going to be the left common carotid, which is again going to break off into the left internal and left external carotid. The next one's going to branch off into the left subclavian. So you can see on this side, even though we had this branch off, this branch then branches off into the right subclavian and the right brachial, same as this turns into the left subclavian and then the left brachial. And as we follow the upper and lower limbs, they're both going to be the same on the left and the right. So I'm just going to follow this, this right side here. So as we come down, we have the brachial. The brachial is then going to split off into the radial and also the ulnar. And then we have the palmar arches. We have the superficial and the deep palmar arches. As we head down the belly, which is going to be the abdominal aorta, we're going to enter into many major branches that are going to feed the abdomen, including the gastric, the splenic, the renal, the superior and inferior mesenteric, the gonadal, the suprarenal, which I don't think is shown here, and then that's going to branch us down into the iliacs. Okay, the iliac is going to be this major intersection here. We have the left and the right iliacs, of course, and then we have the internal and the external iliacs. All right, the internal iliac is just going to feed the hips. The external iliac, however, is going to then run down into the femoral. We have the left femoral, which then feeds into the popliteal. Now, the femoral splits off into the deep femoral and the main femoral. The deep femoral is going to service the thigh. The main femoral, is the superficial femoral, is going to feed into the popliteal. Now, the popliteal then feeds into the tibials and the fibules, or the fibulars, and then into the dorsal arteries of the foot. This is the dorsal pedis, where you're able to get a pulse here as well. And then you follow that out to the metatarsals and the digitals. Okay, so this is talking about the internal arteries that branch off of the abdominal aorta as we travel down. So I already talked about those three major branches, but if we can then travel on our way down, one of the first ones we're going to reach are going to be, we have the bronchioles and the esophageals. These are going to feed off into the esophagus, obviously. And then as we follow that down, we're then going to end up into the intercostals, which feed the ribs. Then we have the pericardials, which are going to feed the pericardial cavity. Following down, we have the phrenic, which is going to feed the diaphragm. We have the superior phrenic and the inferior phrenic. And then as we've traveled down from that, we have the gastric and the splenic. Then we have the suprarenal and the renal, the superior mesenteric, the gonadal, and the inferior mesenteric. After that, and the lumbars, sorry. After that, we're going to feed off. Did I miss the renals? No, I did. So the left renal and the right renal. A lot of these are going to have both left and right as well. So we've reached the iliacs. The iliacs are going to split. Here we're going to have the common iliac, and just like we saw with the common carotid, it then splits into the internal and external. The internal is going to feed the hip tissue itself. The external iliac is then going to run out and then split down into the femoral. The femoral splits into the deep femoral of the thigh and the femoral itself. The deep femoral is going to feed into the thigh tissue, and then as we move down, let me go to the legs and I'll come back to this. Nope. All right. So then I guess I'll finish up here then. As we go from the femoral, that's going to feed into the popliteal, into the tibials and the fibule, down into the dorsal metatarsal and the dorsal digitals. All right, so that's what's going to happen as we split off here, heading down into the femoral. So basically, each of the section of arteries is going to give a branch to supply that region of the body. So here's a scheme of distribution of the different, this is going to be coronary circulation. Coronary circulation, basically, that's going to branch right off of that ascending aorta and split into the left and the right coronary artery. The right coronary artery is going to split into the posterior intraventricular branch and the marginal branch. The left coronary artery is going to split into the anterior intraventricular branch and the circumflex branch. Okay, and then if we're looking at the schema distribution off of the aorta, so here's the arch of the aorta. Again, we have three major branches, the brachiocephalic. Now note, the brachiocephalic splits into the same things that the other two are. It splits into the carotid and the subclavian. Here we have the left common carotid and the left subclavian that are already going to have their own branches off. So that brachiocephalic, again, splits off into the right common carotid. The right and left common carotid are going to do very similar things. They split into the internal and the external carotids. Then they feed into the anterior cerebral and the middle cerebral, and they also are going to have a little bit of crosstalk from that posterior cerebral region through basilar flow. So that basilar flow is going to have kind of a back route way that we can get to the brain that's going to come up of the subclavian through the vertebral. So in that way, we're going to have alternate routes of blood flow in case something gets blocked in the brain. Okay, so that subclavian, which is going to be the same thing on the left subclavian side, is going to feed into the right axillary, then into the brachial. That brachial splits into the radial and the ulnar, which then feeds into the superficial palmar arch, the common digital, and the right proper palmar digital. And it also feeds in, those are all superficial, and then it also feeds into the right deep palmar arch and the right palmar metacarpal. Okay, so there's a lot of crosstalk there as well. And again, that's going to allow for alternate routes of blood flow. Okay, as we are going through the thoracic aorta, We have visceral branches and parietal branches. Basically, are they facing forward or are they facing backwards, right? The visceral branches include the pericardial, the bronchial, esophageal, and the mediastinal. The parietal branches include the intercostal, the subcostal, and the phrenic. So these are going to be doing the rib cages and the diaphragm. Okay. Now, the scheme of distribution from the abdominal aorta downward is that we're going to be going, again, through those parietal branches are going to be the inferior phrenic, lumbar, and medial sacral as we end up in the abdominal. So we just were talking previously to make it clear, the thoracic aorta and the abdominal aorta are separated by the diaphragm. So this thoracic part is the descending aorta, and then the abdominal aorta is going to be servicing the inner organs. Okay, so as we head down through the abdominal aorta, where the visceral branches are going to feed into the celiac trunk, which has left splenic and common hepatic. The hepatic is going to feed into the hepatic artery proper, gastric, and gastroduodenal. The splenic is then going to move down until we go and branch off into the pancreatic and the short gastric, and we're going to head down into the left gastromental. Then the next one is going to be the superior mesenteric, which is going to feed into the inferior pancreatoduodenal, which is basically going to feed the pancreas and the duodenum. Also going to feed into the jejunum, and the ileocolic, which is going to be the ileum and the colic region, also the right colic and the middle colic region. Next, we've got the suprarenal and the renal and the gonadal and the inferior mesenteric, which again is going to get split into the sigmoid, left colic, and superior rectals. So do you need to have every pathway memorized? No. But do you need to have the overviews memorized? Yes, you will need to know the order. And so what I've been mentioning to people who have been coming to lab is that it's easier for me, instead of remembering this, is just remembering which is going to branch off, which you can get from here, which is going to branch off when as you travel down, and that's going to help you remember which organs they service, because they're going to be servicing the organs that are going to be in those areas. All right, so here's the celiac trunk and how it branches off. So the celiac trunk is going to feed into, here again, here's celiac trunk, going to feed into the proper hepatic, which feeds into the common hepatic and the gastroduodenal. It's also going to branch off into the splenic and branch up into the left gastric. As you can see, the stomach here is going to be inverted or turned upward, so we're able to see the organs that are underneath it. This is not how the stomach sits. This is going to be the top of the stomach, and this is going to be the bottom of the stomach, which normally sits here. But my point is that they're going to be fed by these gastromental, the left and right gastromental arteries. The spleen is going to be fed by the splenic artery. Obviously, the pancreas has a ton of vasculature that's going to come from the pancreatic. Superior mesenteric here is going to start feeding into the small intestines. Right, the superior mesenteric feeds into the duodenum of the small intestines and the ileum. And then as we head down, here's a superior mesenteric as well. It's going to feed into the ascending colon of the large intestines, as well as the inferior pancreaduodenal region, also the right iliac, the ileocolic region. And then here's the transverse colon of the small intestines. That is going to be fed here. The transverse and the left colic region are going to be fed by the inferior mesenteric arteries. Okay, and these here are just anastomosis regions where we can have crosstalk. So if we have blockage of blood flow, we can still get there by going around. And again, that inferior mesenteric is going to do the left colic as well as the sigmoid colon and the rectum. So this is the schema distribution throughout the leg. So as I was mentioning, we have the iliacs. We have the right common and the left common in iliac. Same as with the arms, we're only going to demonstrate one because it's going to be the same on the left side. So I'm going to read you down the right common, or the right pathway. So we go from the right common iliac to the external and the internal iliacs. The internal iliacs feed the hip. The external iliacs continue down to feed into the femoral. The femoral splits into the right deep artery of the thigh, or the deep femoral, which is going to feed the thigh, and then follow the major femoral down to the popliteal. The popliteal will feed into the tibial and the anterior and the posterior tibial. The anterior tibial will feed into the dorsal artery of the foot, or the dorsalis pedis, feeding into the dorsal metatarsal and the dorsal digital, also feeding into the lateral plantar, the right plantar arch, the plantar metatarsal. Okay, the posterior tibial also has some crosstalk with this. It feeds into the right fibular and the right medial plantar, which has some crosstalk with the right lateral plantar and that plantar arch. Right, this is all stuff that you're really just going to have to work through and just memorize, lather, rinse, repeat. Okay. So that is arterial flow. Do you have any questions before I jump into venous return?
No, I'm good so far. Thank you.
Okay, yep, of course. I know it just kind of feels like I'm reading right off the page here to you, which is kind of what I'm doing. All right. So if we're looking at venous return, The major one that I want to start with is going to be the vena cava. So the vena cava, we have the superior and the inferior vena cava. Basically, everything is going to be feeding into those two major pathways, right? And so let's start all the way at the tips of our fingers and the tips of our toes and the top of our head and talk about how it gets back to the vena cava. All right, so the proper palmar digital is going to feed into the palmar digital, which feeds into the palmar venous plexus. Now there are two major branches here, the radial and the ulnar, and they both are going to have crosstalk that occurs. Now the ulnar is also going to run alongside the antebrachial, which runs up into the basilic. Here's the median cubital. All of that is going to run alongside, up in the upper arm, we have the axillary here, and the cubital and the cephalic. All of that runs up into the brachiocephalic, which then is, so the subclavian and the brachiocephalic, which then feeds down into the superior vena cava. From the head, we have the superior and inferior sagittal sinus, which drains into the straight sinus, which drains into the transverse sinus, and the sigmoid sinus down through the internal jugular. And we have the external jugular as well. These are both going to feed into the brachiocephalic region, which then feeds into the superior vena cava. Right? So from the abdominal organs, we're going to be draining kind of upward into the inferior vena cava, depicted here. So that's going to start with the inferior mesenteric, superior mesenteric, and the renal. Also the hepatic portal and the splenic, and all of that is going to feed into the inferior vena cava. Now the great cardiac veins, these are going to come from the heart themselves, and they're going to feed into the directly into the atria from the cardiac sinus, from the coronary sinus. So they don't actually enter into the vena cava, they're going to enter directly into the right atria. Okay, I'm going to start with the toes. The left dorsal digital drains into the dorsal metatarsal, into the dorsal venous arches. We also are going to have the posterior tibial and the anterior tibial, which drain into into the popltea through the into the popltea. We also have a region here, which is the small saphenous. The small saphenous drains into the popliteal. We also have the great saphenous, which drains all the way up into the femoral. So basically, we're going to have a connection that's going to be the smaller or a lesser saphenous, which is going to drain into the popliteal, and again, that great, which drains up into the femoral. The popliteal reaches up into the femoral, which again is going to drain up into the iliacs, and those iliacs are then going to reach that vena cava on the way up, right? So this is a scheme of drainage for the head. And as just like we saw before, we're going to have crosstalk. So the sagittal sinuses, the inferior and superior sagittal sinuses are going to drain into the straight sinus and the transverse sinus. There's crosstalk between the transverse sinus and the cavernous sinus. But from this region, we can drain directly down into the internal jugular, either from the cavernous sinuses or from the sigmoid sinuses. And that left internal and right internal jugular are going to drain into the left and right brachiocephalic. Okay? The external and internal jugular are going to drain in as well. That happens through the subclavian and then into the brachiocephalic. All of that drains directly into the superior vena cava. And that looks kind of like this. Superior sagittal sinus draining into, and here's the inferior sagittal sinus. These are both going to be connected by that transverse sinus and the cavernous sinus. And that's going to allow some crosstalk, and then we're going to have some more drainage occurring from the right vertebral, the internal and external jugulars, all of that feeding into the subclavian, then into the brachiocephalic, into the superior vena cava. Schema drainage for the hands. We're going to have the dorsal and the palmar digitals. So these are going to be the veins that are going to be coming from the palmar and the dorsal regions of the hand. The dorsal regions will feed into the dorsal metacarpals and the dorsal venous network of the hands, which has some crosstalk with the accessory cephalic, as well as the right cephalic and the right basilic. The palmar digital can also feed into the palmar venous flexus and the median antebrachial, feeding into the median cuboidal. And that's because we have to have a lot of crosstalk, because this is all going to be returning by muscle contraction. So depending on which region we're going to have muscular contraction, we're going to force this blood flow back up, whatever is the fastest route. The palmar digitals are going to go up through the common palmar digital, through the superficial palmar venous arch, through the right ulnar. On the radial side, we have the palmar metacarpals feeding in through the deep palmar venous arches through the right radial. That's all going to go to the right brachial, through the right axillary. And from the right axillary and the right cephalic, then we drain into the right subclavian, which then feeds into this brachiocephalic and into the superior vena cava. Okay, and that looks kind of like this. The palmar digital feeding into the palmar venous plexus, feeding up through the median antebrachial. We also are going to have the cephalic here and the basilic here. These are going to feed up into the median cuboidal, which feeds the basilic, which becomes the axillary. This side is the accessory cephalic, which feeds the cephalic. All of those are going to come up and join together here at the subclavian, which eventually is going to join with the jugular, and the internal and external jugulars are then going to all feed into the superior vena cava, feeding directly into the right atria. Now, this is the anterior view of the deep veins. So here's the anterior view of the superficial veins. As I mentioned here, we have two different things happening, right? We have the deep veins and the superficial veins that are going to be occurring. And here we go. The deep veins are going to include the right proper palmar digital, which are going to have crosstalk here at the superficial palmar venous arch. We have a deep palmar venous arch and a superficial palmar venous arch. Those are going to lead up into the ulnars and the radials. Again, we have a lot of anastomosis happening here and there, so we have a lot of crosstalk. Those are then going to feed up into the right. Here's the brachial. Right, the brachial is then going to meet up with the axillary and eventually feed into the subclavian and the superior vena cava. Here's a superficial view of the hands showing all the different regions of anastomosis. So here we have the dorsal metacarpal. We have one for dorsal metacarpal for each metacarpal and one dorsal digital for each digital. Actually, multiple different dorsal digitals for each digital. And here's your dorsal metacarpals feeding up into the dorsal venous network of the hand, which is going to be around the wrist, feeding up into the right cephalic. Now we're talking about the drainage here of the abdomen as well as of the brain. So here's the internal jugular and the right subclavian draining into the brachiocephalic, into the superior vena cava. From the abdomen, we have the subcostal and the ascending lumbar draining into the hemiazygos. The hemiazygos and the accessory hemiazygos are going to drain into the azygos. Also draining into the azygos is coming from the subcostal and the ascending lumbar. From the azygos, we're going to go into the superior vena cava. So both the right brachiocephalic and the azygos are going to drain into the superior vena cava, and then, of course, into the right atrium. This is showing the abdomen in terms of where we're having a series of drainage for our different, remember we had all of these regions that were going to have arterial flow as well for the abdomen, and then the internal organs. So coming up from the leg, we have the femoral. That's going to meet up with the iliacs. Here they have the common iliacs. So we have the external and the internal iliacs meet up with the common iliacs. Common iliacs run up, and now we are going to have the ascending vena cava, basically, which is going to meet up with, here's the inferior vena cava, meeting up with the lumbars, the ascending lumbar from the left and the right. So here's the right, and there's the left. Then we're going to meet up with the renal, the gonadals, the subcostals. Here's the suprarenals, both the left and the right suprarenals. And then here's that hepatics. And that's important because remember, the liver is going to be responsible for filtering blood, and so this hepatic region is going to be getting a bunch of the blood flow back from the liver. The liver is going to need a lot of blood supply to be able to undergo the metabolism it's undergoing to filter through the blood, so it's going to have multiple different venous returns. So these are the hepatic veins that are returning here. As we follow up, here we have the hemiazygos, the esophageals, the bronchial and pericardial and mediastintials. That's all going to be right around. We have the azygos region. All of those are going to feed into the superior vena cava. Okay, again, coming up from the legs, left internal iliac, left external iliac into the left common iliac. Common iliacs on both sides are going to turn and come into the vena cava. That ascending vena cava is going to be joined by the lumbar, gonadal, renal, suprarenal, hepatic, and inferior phrenic, right, until it drains in through the inferior vena cava. Then this is showing the venous return of the legs. Here we have the anterior view, or the front and top, and here we have the posterior, or the back and bottom. Let's do the anterior first. We have the dorsal digitals, dorsal metatarsals feeding into the dorsal venous arches, up into the anterior tibials, as well as the small saphenous. The small saphenous is going to branch off and meet back up at the popliteal. The great saphenous, however, is going to run all the way up and meet at the femoral. Following that popliteal up, we're going to be joined by the internal and external femorals, and of course the great saphenous, which is then going to turn into the femorals and then up into the iliacs. Internal and external iliacs are going to feed into that inferior vena cava. From the posterior view, so the bottom and back, we're going to have the plantar digitals and the deep plantar venous arches feeding up into the right medial plantar. We also have the right lateral plantar and the right plantar metatarsal feeding up into the right medial plantar, which is then going to come up into the right great saphenous. Again, that's going to run all the way up to the femoral. And then we also have the right fibular here, lots of anastomoses here to have crosstalk. Remember, this is when we're going to be having these deep veins are going to be the ones that are susceptible to deep vein thrombosis. Most of the venous return from this region is going to be coming from that skeletal muscular pump that we were talking about. Here's our right small saphenous, which is going to drain into the popliteal. That popliteal is going to come up and pick up with the femoral. The internal femoral and the external femoral are then going to turn into those iliacs, right? Those iliacs then are going to turn into the inferior vena cava. So here's that scheme of drainage. We have the right dorsal digital, right dorsal metatarsal to right dorsal venous arches feeding into the great saphenous, which goes up to the femoral, and the small saphenous, which goes up to the popliteal. We also are going to have the plantar digital, plantar metatarsal going into the plantar venous arch, going up into the right medial and lateral plantars. Also the right dorsal venous arch here coming into the anterior and posterior tibials, up into the right popliteal. Popliteal is going to feed up into the femoral. Deep vein of the thigh is also going to feed into the femoral. That leads up into the iliacs. The iliacs, external and internal, are going to feed into the commune and then turn into the inferior vena cava. All right, so this here is talking about the abdominal organs and the drainage here that's going to occur. Some of them are going to be draining into the superior mesenteric veins. That's here. Some are going to drain into the splenic vein. Some are going to drain into the inferior mesenteric vein. And this is basically showing you which of them are going to drain into what. So draining into the superior mesenteric vein, we have the ileocolic, the right colic, and the pancreoduodenal, as well as the jejunal and ileal, middle colic, and right gastromental. Draining into the splenic, we have the inferior mesenteric, the left gastromental, the pancreatic, and the short gastric. And draining into the inferior mesenteric, we have the superior rectal, sigmoidal, and the left colic. All right, so now we're moving on. This is all talking about the hepatic portal circulation here, so I apologize. I should have had hepatic portal circulation here and not before the previous figure. I put it in the wrong spot. Anyway, hepatic portal circulation is going to happen when we have veins coming from the stomach, pancreas, and large intestines. Remember, this is all some things that are going to be occurring with digestion. As well as from here, small intestines, portions of large intestine, stomach, and pancreas. These are coming in from the superior mesenteric vein as well as the splenic vein, coming into the hepatic portal vein. So those are going to drain together into the hepatic portal vein, feeds into the liver, and then that's going to be fed. The liver is going to be fed straight off of the abdominal aorta through the proper hepatic artery into the liver. And then these hepatic veins are going to be venous return. So the liver is going to be receiving deoxygenated blood for filtration as well as oxygenated blood for metabolism. All of that is going to enter into the hepatic veins and then going through the inferior vena cava and draining into the right atria. All right, so now we're talking about pulmonary circulation. And pulmonary circulation basically is going to be happening coming out of that right ventricle through the pulmonary artery, through the pulmonary artery. This artery is going to be depicted as blue because it is not oxygenated yet. Going through that pulmonary valve, pulmonary trunk into the left and right pulmonary arteries, going into the actual lungs itself. We're going to have gas exchange, and we'll talk about the process of respiration and gas exchange in a different chapter. But trust me, we're going to end up with oxygenated blood, which is then going to return in through that left atria and then to the left ventricle so that we can then send it out through systemic circulation. So what happens? So here we're going to have out of the right ventricle to the pulmonary trunk, pulmonary arteries, the left and right pulmonary arteries, till we reach the air sacs of the right and left lungs, where we're going to have gas exchange occurring. At that point, we're going to have return through the pulmonary veins, the right and left pulmonary veins, into the left atrium, when that's going to go to left ventricle and then out through the aorta for systemic circulation. So pulmonary circulation and systemic circulation are equal and opposite, and approximately the same volume of blood is into pulmonary circulation as is entering into systemic circulation at any given moment. Okay, so some differences between fetal circulation and adult circulation is that we have this specialty ductus arteriosus, so we have a fourth branch off of the aorta, which is going to turn into the ligamentum arteriosum in the adults. We also are going to have a hole called the foramen ovale that's going to allow blood to flow back and forth between these two atria, which is good because that means that if we have too much pressure, the pressure will overflow into a different chamber instead of causing rupture of the chambers. Obviously, in the adult, we have separation, but we have a little dimpled region called the fossa ovalis, which is a remnant of that foramen ovale. Additionally, we're going to have an entirely extra set of supply for fetal circulation where we're getting the blood instead of from the lungs, right? So lungs and the heart are going to be kind of purple. We're going to be getting our oxygenated blood through this specialty organ known as the placenta. Okay, I will not be quizzing you on fetal circulation. I will not be quizzing you on the development of blood vessels. Again, I left that in case anyone had any interest in it. As we get older, the cardiovascular system tends to lose compliance, so we end up with less flexibility of the aorta. We reduce our cardiac muscle fiber size, and we end up with progressive cardiac muscle strength loss, as well as reduction of cardiac output and a decline in our heart rate, as well as an increase in our systolic blood pressure. We also can have an increased incidence of coronary artery disease, which is when we have plaques building up on the inside of our arteries, or congestive heart failure, as well as our arterial sclerosis. So all of that can increase as we get older. This talks about some disorders or homeostatic imbalances, such as hypertension or high blood pressure. And typically we have primary hypertension, which is not attributed to any particular cause, and secondary hypertension, which has an identifying underlying cause. And that brings us to the end of our exam review. So I'm going to open the floor up to any questions and then go ahead and stop my video. So thank you guys for listening to this extremely long 2.5-hour review session. All right. So I am stopping the video here, and it's just us now. So do you have any questions?